So welcome everybody and greetings from a very warm Sri Lanka. On behalf of the Endometriosis and Adenomyosis Association of Sri Lanka, it's a great pleasure to welcome everybody who has joined our webinar. We thought of this topic because the cul-de-sac is the place where most of the action is in endometriosis. The importance of that is that that's the very place that people shy away from, and they don't want to touch it, and resulting in suboptimal treatments. Obviously, this has been of great interest to a lot of people, and for this webinar today, we have had more than 230 registrants from 17 countries. So I really hope that you would make the most of this opportunity, and next week when you go to work, I hope we will make you comfortable in dealing with getting into the cul-de-sac and dealing with the problems there. So once again, thank you for joining us. I just want to brief you about our format. We have speakers from many countries, including Sri Lanka. Two of them are of Sri Lankan origin, although they are working in other countries at the moment. We are going to have the presentations, and these will be followed and preceded by just a short break for the advertisements. So please bear with us while we are showing our sponsors' messages. But that won't be long, I want to assure you. Also, I want to remind you not to forget the Asian Congress on Endometriosis, which is going to be held in October from the 28th to the 30th in Colombo. We're going to follow a hybrid format, so you could join us from the comfort of your home. But why not you make use of it to visit our beautiful country? You've been kind of restricted at home, and this will provide the best opportunity for you to take a break from this COVID threat and get a well-deserved break. And I assure you it will be a fully worth the visit. And we're going to show you just a couple of short tourist videos as well. So in this session, I'd hope that you would have, and I'm sure that you will have a lot of questions. Feel free to ask them, and I'm sure our experts will be very happy to answer them. We will try our very best to accommodate as many questions as possible. We plan to have a session at the end of these presentations as well. So without any further ado, I'd like to thank you for joining us. And it's a great source of encouragement for us. And we're going to, because of this success, we're planning to have another session in a similar way on a related topic somewhere in early May. So I'd like to welcome you and to join that as well. I want to also thank the speakers in advance for sacrificing their time and talking to you about this very complex and very difficult area and sharing their experiences with us. So thank you once again, and for joining us, and enjoy the session. And I hope you gain much from this. Thank you very much. So we are going to move into the first talk of this seminar. So it will be delivered by Dr. Damika Silva, who is a senior obstetrician in Sri Lanka. He's the head of department in the obstetrics and gynecology at the University of Sri Jawaharlal. He's an honorary consultant in the Colombo South Teaching Hospital. He's had a distinguished career as a postgraduate, winning the medal for the best performance in the MD final examination. And he's a leading exponent of laparoscopic surgery. And he's also obtained the interfaculty, inter-university diploma in endoscopic surgery from France. So over to you, Damika.
Hello.
Yes, Damika, you can speak up now.
Okay.
So the stage is yours. Thank you.
Thank you very much, sir, for inviting me to join this session. And I have been given a rather difficult task of talking about pelvic anatomy in 30 minutes. So I'll try and do justice to this session. I hope I'm very clear because my video appears very slow. Can I just check whether it's okay?
Yes, you're loud and clear. That's fine. Please carry on.
Okay. Okay, so I'll share my screen. Right. Okay, so if we look at laparoscopic pelvic anatomy, basically as surgeons, as gynecologists, what we need to look at is that it's made out of, for ease of operation and for us to understand, probably we need to look at the whole of laparoscopic pelvic anatomy as like in pelvic spaces. So although we divide these into pelvic spaces, but all of these spaces are interconnected to each other, and therefore the division is just artificial, and it makes us easy to understand and operate on them and understand the anatomy. So if you look at all the spaces, there are some medial spaces which we need to look at, which is the we have the retropubic space, the uterovesical space, the rectovaginal space, and the retrorectal and the pre-sacral space. These are the medial spaces that we want to look at. And on the sides, we have the paravesicles and the pararectal spaces. The paravesicle is divided into two, the lateral and the medial paravesicles, as is the pararectal, which is divided into the medial and the lateral pararectal spaces. So these are mainly what I want to go through. So I'll just, first we'll speak of the retropubic space, which is the space behind the pubis. So this is what we do. Why is it important? Because these are the surgeries that we do in the retropubic space. We do the Birch-Kolper, and there's a huge awakening of interest in the Birch-Kolper suspension again after the problems with the meshes. We do paravaginal repairs for reimplantation of the ureters. We need to mobilize the bladder from it, and for mesh removals. So if we quickly go through the anatomy, you see the bladder, the pubic symphysis, and if you look at all these, the structures, you can see that it's between behind the pubis, and on the lateral sides, you get the external iliacs and the obturator vessels. and on the medial you get the bladder. So what is important in this space is that when we go into it, we have to remember from the midline, the obturator vessels are situated about 6 centimeters laterally. So it's very important when you do our surgeries not to go too lateral. And then just 1 centimeter above the obturator, we find the external iliac vein. So we need to be very careful when we dissect this place. So quickly, if you look at it, the endopelvic fascia is there and the obturator internal muscles there, which I showed on the slide. So this is a video from the from a birch corpus suspension. So initially, it's of course in this phase, it's always better to fill up the bladder a bit so that this 300 ml of normal saline is put in, and the bladder can be, the space can be approached in any way. This one is a bit of a medial approach, but I think probably the safest would be to go through the obliterated umbilical arteries on the sides, and the chance of falling into the bladder is very small that way. So basically the space is divided as you go into the space. The most important thing is to see on the right side now is what we call the lighthouse of the retropubic space. You can see the whitish thing, that is the iliopectineal ligament. And this space is normally here, there is a bit of bleeding, but usually the space is extremely avascular, and we tend to, in laparoscopy, it's easier. What you can see on the right side now is the white line, now the arcus tendinous, which is where the endopelvic fascia is merging with the lateral side walls. In the middle, you can see the bladder, and when we slowly on the lateral side, what I'm showing now is the obturator nerve and the vessels, and just behind that, just over that will be the iliac, internal iliacs. So that is the obturator internus. So this is basically the space, and what has been lifted up is the paravaginal fascia, to which we will put the stitches. So if you look at the vesico-vaginal, which is between the vagina and the bladder, or the uterus and the bladder, we do a whole lot of surgeries here. You can see all these we need to open into the vesico-vaginal and the vesico-uterine phase. So there's a huge number of surgeries which you do. So it's very important for us to know. Basically, this is the space between the bladder and the cervix. That is the space. But you can see that the cervix, we have the vesico-uterine, or so-called bladder pillars, and then the pubo-cervical fascia is there, and then the bladder trigone is there. If you go deep into it, you meet the proximal uterine and the bladder trigone, and this is the vesico-vaginal space. So deep down are the vaginal and inferior vesical arteries are there, and the ureter is on the side, which will go in later on. So these are the contents which I just showed you, and they will go into the space. You can see this is an approach from the lateral side, not from the medial side. And usually the vesico-vaginal peritoneum can be lifted up. If there are scars there, it might be difficult. So for a normal, we start the dissection about 1 centimeter below the reflection of the peritoneum. So we need to dissect about 4 centimeters for us to do a normal hysterectomy. That is where there is safe for us to cut into the vagina. However, if it is a radical hysterectomy, we might need to even go deeper. And of course, if we need to place a mesh for mesh repairs, we will need to go more deeper to place the mesh in that area. So this is basically we are going into that space, and this normally will have to be developed even in open surgery or laparoscopic surgery. This space we need to develop this space. So this is just why we use it. You can see this is the vesico-vaginal fistula. So you can see the stenting. I just put it in just for interest's sake. This was a rather large, and you can see the space is getting developed. You can see this is the vault, vaginal vault, and up there is the bladder. So this space needs to be developed for these surgeries when we do this surgery. So that is So it just, I'm going to go hurry through and I'll show you the last bit. You can see that the vagina is getting sutured separately. This is the bladder getting sutured and the vagina is getting sutured separately. So the space will have to be developed. This space has to be developed to do these surgeries. Right. The paravaginal space, usually it is developed in radical hysterectomies. Normally we don't go into this space because it's safe for the ureter, because when we develop into the paravaginal space, the ureter is quite safe for us to do it because we lateralize the ureter in doing this. But these are the surgeries that are performed. So it's a very small space. It's called the yabuki space. You can see, I will go very quickly. You can see the space. It's lateral to the bladder pillars, and the ureter is lying on the more lateral side of it. So the yabuki space, this is not my video actually. So I just, so because I didn't get a beautiful view on it, so I got this. So this, you can see that the space is being developed. On the right side, the vesico-uterine space is there, and the bladder pillars are medial, and this space is getting developed, and that is the yabuki space or the paravaginal space. So the ureter on this side will lie lateral, while medial border is the ligaments, the vesico-vaginal or the bladder pillars. That is how the ureter lies in this. So this space is called the yabuki space. So the next space, which is a lateral space, is the paravesicles. Now the whole paravesical space is, I will show you the two spaces. If you see, the whole paravesical space is divided. If you look at the obliterated umbilical artery, it sort of divides the paravesical space into two. On the lateral side, between the external iliac vessels and the obliterated umbilical artery, we have the lateral paravesical space. The important structure that is living there is the obturator nerve. On the medial aspect is the, what is bordered in green is the medial paravesical space. So it's medial to the obliterated umbilical artery, and the ureter lies on the medial side of it. So what is important here is it's important for our pelvic node dissections, and on the posterior aspect, the uterine artery, as you see, borders it. So for development, especially for radical hysterectomies, these spaces need to be developed. So as I mentioned earlier, the lateral paravesical, the most important one, is the obturator nerve. So this is a short video of that. Usually the paravesical space is entered by cutting into the round ligament, and then you fall directly into the paravesical space, or you can dissect over the external iliac and external iliac artery and vein, and then you can extend forward, and then you can go into the paravesical. But the easiest to fall into it is to cut through the round ligament, and you fall into the paravesical space. This space can be developed right up to the pelvic floor as it is being done. And so mainly remember, this paravesical space is divided sort of arbitrary into two by the obliterated umbilical artery. Now what we are seeing here is, I have dissected it a bit towards the head end of the patient, and what we are seeing is the external iliac artery and vein, which are here. So I will skip slightly so that the dissection is still going on, and what is coming into view now is the obturator nerve. Remember, the obturator nerve lies in the lateral paravesical space. And now what's coming into view is the obturator umbilical artery. You can see that the obturator umbilical. So it sort of divides. So where now what I'm holding now with my left hand is the obturator umbilical artery, and on this side you can see that's again the obturator nerve. So here, of course, it is on the psoas muscle again. The dissection has come over the psoas muscle, and what we can see is the genitofemoral nerve. This, okay. Right. So next is the pararectal space. Now, if you look at this diagram, the pararectal space is divided into the outer pararectal space, which is called the Latsko, and the inner pararectal space, sort of mainly by the ureter. So when you locate the ureter, if you dissect between the internal iliac vessels and the ureter, we are going into the Latsko space. And if we dissect between the ureter and the lateral border of the rectum or the large bowel, we fall into the Okabayashi or the inner pararectal space. So the inner pararectal space, you can see there are nerve fibers of the hypogastric plexus, and if you look at a video of the lateral pararectal space, which is the Latsko, the dissection is between the internal iliac vessels and the ureter. Mainly, we should be able to see the hypogastric nerves there. And it gives us, when you go down deep, we can go into the sacral nerve roots if necessary. So these are avascular spaces which we can develop as we go on. So it's a different video from the presacral, from the Latsko space. You can see again, if I remind you all, the dissection goes between the internal iliacs, which we can see here, and the ureter. So that is the avascular space or the lateral pararectal space. You can see the internal iliacs here. And if you look at the medial pararectal space now, the dissection is usually between the ureter and the lateral wall of the bowel. And this space can be developed until we see the pelvic splenic nerves. This is the most useful space for surgeons who perform endometriosis surgery, where the bowel needs to be medialized so that we'll be able to, and the ureter lateralized so that we'll be able to dissect all the endometriosis of the bowel safely, because, and these will go on to meet the the rectovaginal space, so that this is continuously there. So these are the pelvic splenic nerves, which you can see quite deep underneath, and that is the Okabayashi space. Right. Now, if you look at the rectovaginal space, This is the space between the rectum and the vagina. And this is where most of the endometriosis will sit. And also this is the area where we will need to dissect to bring down the bowel, so that when we resect the endometriosis of the uterosacral ligaments, we will have to, the bowel will be safe. And by going into this space and with the pararectors and meeting them under the arch of the uterosacrus, and when we bring the bowel down, some endometriosis will be left on the bowels, which we can either do a shaving or a discoid or a segmental resection, while we can shape the endometriosis of the uterosacral and the retrocervical region when necessary. So you can see this is the space. The rectum is below, the cervix is on, and the this is the rectovaginal space. So this is a dissection that has occurred in the rectovaginal space. You can see even the bowel has been brought down. So this is the, and you can see the nerves are also visible actually after the dissection. Right. Now this, the presacral, the space just above the sacrum is the presacral rib, and if you go down beneath the rectum, it's a rectorectal space. Now the rectorectal space is developed when we do a segmental resection of the bowel due to endometriosis, and the presacral space is developed because this is where the superior hypogastric plexus lives, and when we do presacral neurectomies, this space has to be developed to do it. So quickly, if you look at this, you can see the middle, most important, one of the middle, most important when the middle sacral vessels are there, and the presacral vessels. The urethra is quite nearby, and the superior hypogastric plexus is in there. Right. So this is a development of the presacral space. You can see that the nerves are quite large, and you can see these are the nerves of the hypogastric plexus, superior hypogastric plexus, which has been lifted up prior to them being getting dissected for a presacral neurectomy. So this is a dissection of the lateral pelvic wall. And this dissection was done for a woman who had extreme sciatic pain, and so you can see that the dissection is going on very slowly. What is being used is a bipolar diathermy and cold scissors. What is being held is the dissection is between the psoas muscle. This is the left side of the pelvis, and you can see the genitofemoral nerves on that. And the space which I'm descending into is the space between the psoas muscle and the external iliac arteries. So as we go into that space, when we develop that space, and that is the bluish on just under the external iliac artery is the external iliac vein. And this space, we should be able to now, when we are going there, we should be able to see the obturator nerve, which lives in the obturator fossa. So that is the approach that for, if necessary, for lymphadenectomies or for to approach even the sciatic nerve, this pathway is there. So you can see the obturator nerve now coming into view, and that is the obturator nerve. If you go deeper yet, you will meet the sciatic nerve. Now slowly the from the right side, the obturator nerve is medialized, and then under the obturator nerve, the anatomy becomes very variable. This is the sciatic nerve, which you can see left side. That is the sciatic nerve which I am touching. Right. So under the obturator nerve, the anatomy becomes a bit variable. The obturator vessels, the veins, sometimes, so you have to be very, very careful and dissect it very slowly to make sure that you do not harm any major vessels. So I'm going to speed this up a bit. And this is the dissection from the medial side. You can see now the external iliac vessels are on the left and the obturator nerve can be approached this way as well, and slowly the obturator nerves can be approached that way as well. Right. So that is what I'm holding is the obturator umbilical artery, and what is going there from there is the uterine artery, which I held. Right. So quickly, I think a few more minutes, and quickly I will go through now the most important nerves that we need to know are the obturator nerve. You can see origins from L2, L3, L4, and it has the anterior branch and a posterior branch, and you can see what it innervates. So if we harm it in any way, we will get the problems associated with the muscles and the sensory. So the hypogastric plexus, if you see, we have a superior and a inferior hypogastric plexus, and the superior hypogastric plexus lies on the sacrum, and the inferior hypogastric plexus lies down below. You can see the splenic nerves, you can see the inferior hypogastric. So these are the nerves that we need to understand. So the inferior hypogastric plexus, of course, has things to do with the bladder, the distant colon, right, and the vagina, and these are the ones that it supplies. And of course, the sciatic nerve, because we get endometriosis on the sciatic nerve, and this presents with very serious, very painful sciatic pain. So therefore, we need to know that this is how it supplies. So the nerves, of course, if you just look at the nerves, there are only sort of nerves which we need to know the obturator, we need to know the splenic nerves, we need to know the plexuses, and we need to know the sciatic nerve roots. So these are the nerves actually that we meet often in the pelvis. So this is just the nerves are just showing a presacral neurectomy. And this is the dissection into the retro. Actually, when you go down, you meet the retrorectal space. And these are the nerves of the superior hypogastric plexus, which is being dissected. You can see how large these nerves are, and a part of it is dissected off for pain relief, which can be quite effective. If you look at the hypogastric nerves, there are two on both sides, and they are the connection between the inferior and the superior hypogastric plexuses. I'm going to go faster. You can see how the two hypogastric nerves come from there and they join at the sacrum. You can see it branching off from one side to the other and joins at the superior hypogastric plexus. And if you look at the sacral nerve roots, these are normally the S2, 3, and 4, and they lie. If you want to dissect them, you have to dissect into the piriformis fascia, and they lie deeper to the internal iliac veins. So you have to go slightly under the internal iliac veins and then enter into the piriformis fascia, and there you can develop this nerve. So you can see the sacral nerve roots getting developed, and you can see the pelvic plus splenic nerves, which I showed earlier. You can see them like silver threads there. So these need to be developed only if there is endometriosis involving the sacral nerve roots, or if there's anything, any problem, right? Right, so I think I have gone through it, and it's just that want to show you all this information about anatomy is available in the Sri Lanka Journal of Obstetrics and Gynecology. There are 6 articles if you are interested, especially for the trainees, where these spaces are explained. So thank you. I think my time is up. Thank you very much.
Thank you, Damika, for that excellent presentation and very detailed account of the pelvic anatomy. And we are going to hear from you later in the evening as well. And I'm sure you will show us how these come into use, the knowledge of anatomy. So thanks very much again, and we look forward to hearing from you again. So we will now go into the next presentation, and we will first have the advertisement break, and then we will move into the talk.
Today, we're celebrating our 350th anniversary. Looking back, it's easy to take it all for granted. The discoveries, the developments, and the many achievements. But progress wasn't only our goal, it was also our reward. From the dawn of modern science, the birth of our company, to our arrival in the new digital age. 350 years of defining the future. Today, more than ever, we continue to embrace tomorrow. And together with our partners, we pursue our curiosity, push boundaries, and explore the unknown. Discovering answers to questions that have not yet been asked. Here's where it starts to get interesting. Where Eureka becomes, that's funny. Where vibrant science and technology come to life. And where new ideas are born. Here's to the future. Here's to curiosity. Always curious. Imagine the next 350 years.
So we are moving on to the next presentation. We have Dr. Prabodhan Ranavira. He's graduated from the University of Colombo in 2005, and he spent 2 years at Whipps Cross Hospital in London, and he became a member of the Royal College of Obstetricians and Gynecologists during that time. And he joined the Faculty of Medicine, University of Colombo in 2016 as a lecturer. He has received the Shan Ratnam Young Gynecologist Award of the Asia Oceania Federation of ONG, and he has also obtained the International Inter-University Diploma in Benign Gynecological Endoscopic Surgery from the University of France. He also has received the Certificate of Higher Education Teaching from the University of Colombo, and accreditation by the Staff Education Development Association of the United Kingdom. So Prabodhan is going to talk to us about diagnosis of deep endometriosis. Prabodhan, it's all yours. Thank you.
Good evening from Sri Lanka to you all, and thank you, Professor Hemantha Senanayake, for giving me this opportunity. So I'm going to share my screen. Just give me 1 minute, and yeah. Right, so I'm going to talk to you about the diagnosis of deep infiltrating endometriosis as a kind of a preempt for this proper session about how to kind of for our other speakers. Now, when you talk about the diagnosis of endometriosis, still we consider the gold standard as the diagnostic laparoscopy, but because it involves giving anesthesia and having a two-stage procedure, like one to diagnose and then a proper surgery later. And so potentially it's though it's considered as a gold standard, but it can, we are putting a patient through a procedure which have possible complications. So as surgeons, we would like to have a better pre-op assessment and reserve diagnostic laparoscopy in rare instances where we find it difficult to diagnose. And when it comes to the preoperative assessment, the ultrasound scan, and especially the transvaginal ultrasound scan and the MRI, plays a key role. And in fact, there are many studies which have actually kind of compared the two ultrasound scans, and the ultrasound scan and the MRI, comparing the two for the accuracy. And surprisingly, it has been shown that the transvaginal scan, if it's properly performed, has equivalent or accuracy to MRI. And also in the 2017 meta-analysis, as well as a systemic analysis, also shows that when you compare the both has a similar accuracy when it comes to diagnosing deep infiltrate endometriosis. And in fact, in 2020, there had been a larger study which kind of compare the accuracy of diagnostic accuracy of ultrasound and MRI in mapping deep pelvic endometriosis using the what is called IDEA consensus. So it also showed that both are similar. However, MRI still plays a key role, especially in instances where we can't do a vaginal ultrasound scan, especially in sexually not active women or not giving consent, severe vaginismus patients. So we can't do ultrasound scan vaginally. The MRI still plays a role. And also when it comes to cases where we are not very sure of the diagnosis, we think of a possible malignancy or sarcoma. So that also the MRI is superior to ultrasound scan. Now, the good thing about ultrasound scan is it's very easy to perform. It's almost has become a bedside test. As we have examined a patient, ultrasound scan also, if you're performing it, it becomes a easy to perform bedside investigation with almost equal results as of an MRI. And the one of the key important thing in when you're performing ultrasound scan, you are with the patient and you can communicate with the patient. So that will allow us to symptomatically when it comes to a nodule, because sometimes in the MRI you see a nodule which may not be symptomatic for the patient. But when you are doing the ultrasound scan, you can communicate with the patient and see what nodules are tender, because endometriosis comes in a very wide spectrum of diseases, and some with little endometriosis have severe symptoms, and some with severe disease has no symptoms at all. So it's very important in the today's context when we're treating a patient and why we are treating the patient. So it will help us to kind of prioritize what what extent that we have to do the surgery, and how to treat it the best to fit the patient. And also as a sonographer, you have the tactile sensation through the probe. It's like it's kind of extension of your fingers when it's when the probe is in the vagina, and sometimes when you put the probe into the posterior fornix, you feel like you hit something rock solid. Then you know that this patient has severe endometriosis, or the uterus is fixed, you can't move, and whereas you have the symptoms. So that two-way communication between the patient and as the sonographer you will also add to the accuracy as well as for the planning of the surgery. And of course, it's cost effective and very easy to perform, as I said, very quick, don't need to wait for dates and all that. Right, so today my objective of this discussion is to kind of show you a very practical approach to evaluate a patient who is suspect of endometriosis by ultrasound scan. So the objective of performing ultrasound scan, now when we perform, we have to have an idea of why we are doing it. So we are evaluating a patient's etiology symptoms. So if the patient says she has pain during menstruation, we are looking for adenomyosis or endometriomas. If you are looking, if the patient says she's have deep dyspareunia, we are looking for nodules in the POD or uterosacral ligaments. And we want to map the disease, where the disease is, whether the bowel is involved, what is the extent of bowel involvement, and so the extent and the severity disease. So all this can be assessed reliably by ultrasound scan, and we have to do it in a very systematic way. So by sticking to a system, we will it will be easy for us to go through the what you call the procedure, right? So first of all, it's about consenting. You have to take a proper consent about the vaginal examination and tell what she's expecting, because sometimes you're going to cause pain and you have to tell the patient you can stop the procedure at any time. And all these are very important when you are having a patient there and communicating with the patient and to build the trust. And position of the patient is very, very important when you're performing a transvaginal scan. You have to have a little bit of a leg up position so that you can do the maneuvers, and there are specifically designed tables for that. But if you are in a sometimes poor country like us, where we don't get the beds in all centers, just putting a blanket under the buttocks or just under the pelvis will have that lift, so that we can do the maneuvers very easily at the bedside, or even a pillow. So that will give us the needed lift to put our hand down to get the uterus in view. Right, and the orientation of the probe is also very important, because you need to know where you are, right? And where is your anterior, where is your posterior, where is the caudal region, where is the head side of it, or that's very important, and where is left and right, because when you're mapping, and each person has their own likeness, so we don't know, like each one of you will have their own ways of doing. Some will have the probe coming from down and the screen is different, so each one you have to know your orientation well when you're using the ultrasound scan. A little bit of anatomy, as Dr. Dhammika told you earlier. So we are mainly targeting today this area, what we call the cul-de-sac, which is actually behind the upper part of the vagina, or the posterior part of the vagina, just behind the. So this area we'll be mainly focusing today, and Right. So when we start performing the ultrasound scan, it's important about doing a transabdominal scan before you start. Because sometimes you will miss large fibroid, large cysts, big endometriomas, and also it will give us the opportunity to check for the kidneys for possible hydronephrosis, which will indicate that there's an involvement of the ureter. And once you start, so you will kind of uh, go through the uterus. So traditionally we look at the uterus, its mobility, tenderness. So these features has to be demonstrated, and the vagina and the what they call the posterior the POD should also slide very easily with the probe movements, which will tell us. And now if you have a uterus where you have antiflex and then suddenly there's a retroflexion, acute, and it won't move. Like in this vein, we know that there's endometriosis and adhesions in the POD, and the most likely the POD is operated. To hold the uterus in this position. So if you do the ultrasound scan, you see this sign like a S with anterior, and then there's acute retroflexion. It's very likely that this uterus is fixed with obliterated cul-de-sac and possible endometriomas or nodules along its posterior surface of the uterus. So that's important. And similarly, the ovaries. So ovaries should move very freely, and like when you push with the probe, you can in either sides. And now here, though the bowel is moving against the ovary, you can see that it's attached in a with a wide base to the posterior surface of the uterus. So this ovary is attached. So we look at the ovaries again, the mobility and all that. And the other important thing is the bladder. When you start your scan, so this is the normal bladder where we push the anterior, then you can see that it nicely moves. And in endometriosis, that you can see there's a big nodule here in the posterior fornix, and some part is not there. It's a nodule, so you can see it. So it's important that you push to the anterior fornix of the vagina and then try to assess the vesicovaginal pouch. Now we'll come to the main focus of our talk today, and which will go in line with our the next speakers with the surgeries, right? And to assess the POD, it's important for us to put the probe in the correct position, and then and the normal vagina we can see. Right, and you can see this happening. And then if you have a nodule, right, so the vaginal nodule, you will see, you can see that there's a big, when you go through the vagina, you will see there's a big nodule, and the patient will have pain if it is active when you push it in the posterior fornix. So you know that it's very likely to involve with the uterosacral ligaments as well. And when we assess the bowel, it's very important because from the ultrasound scan, we can actually assess to about 25 centimeters from the anal edge to somewhere here in the descending colon, which will give us an insight of the involvement of the bowel and where the endometriosis is. And if you look at the bowel, you will see a hypoechoic area, which is the muscle layer, as well as the submucosal layer and the mucosa, which is little, the submucosal layer is little hypoechoic, and again you have another hypoechoic area, which is the mucus area, so mucosa. So this will so you can go through it, and you have to know that the bowel is in like it comes in a different angle. So you're looking at this hypoechoic line throughout the bowel, and you can go up to even 25 centimeters up, and you are looking for any breakage in this line, right? So if you now, like this earlier we saw the normal anatomy where the bowel is not involved. And when you have a valve, you have to be mindful of where it is. Now this nodule is coming from the muscle layer, and in this nodule it has invaded into the bowel. So this will have deep infiltration that will might need for us to go for a resection or discoid resection when you perform endometriosis. But this one, we may be able to do a shaving and get off it, right? So it depends on, and when you are doing the scan, it's important. Now here, it's just a nodule on the bowel, and then it's get attached to the uterosacral, and sometimes the other structures also get attached, like the ovaries. So it is important, if you when you see the bowel nodule, you will see that it comes, and then you will see a nodule suddenly appearing in now this is in the muscle layer. And again, when you see it, you need to measure it anterior and posterior, and also try to estimate the distance from the anus, because when you're performing the surgery, sometimes it will be useful if you know the distance with the anus where that nodule was, especially on the bowel, especially if you can't see it. So you have to measure the size of the nodule, how far is from the anus, and which layer. Is it the muscle layer, and does it gone into the through the myometrium to the mucosal layer, and all is important. And if you see a bowel, and you have to know whether it's stuck to a vaginal nodule as well, or there is a uterosacral nodule, whether the nodule is attached to the uterus, ovary, or sometimes even to another bowel. So it is important to document all this. And when you see the nodule, to do your probe up and down to see anterior and posterior, left and right, to see what are the other structures attached to the bowel, so that we can have a accurate picture when we go in. Uterosacrals is the other one, and it needs a little bit of more experience, especially when the uterosacrals are not involved, to demonstrate them, and you need to have a little bit of fluid in the POD. If there's no POD, it's very difficult to see the uterosacral, but with time, especially when there's nodule, when you start scanning a lot, you will start seeing these nodules, because most of the time when you have a uterosacral nodule, there are a lot of other structures attached. So it's very difficult to see them individually, but you can suspect when there's a bowel nodule or ureter involvement, ovaries getting stuck there, because most of the time the endometriosis starts from uterosacral ligaments and then develop into a more severe disease. So by the time we diagnose it, it's very difficult to find uterosacral ligament nodule individually, but it will be there, and we need to resect it to give a symptomatic relief to the patients. So when it comes to obliteration of the POD, it's again very important. And when we did the scan, you have to look at the POD, and then you have to see the vagina as well as the cervix moves across the POD to say it normal. Now, when you see this slide, you see that nothing moves. Everything is stuck. Play this again to the cervix. So it's basically, this is the normal anatomy, and this you can see a uterosacral nodule. So when you do the ultrasound scan, you might see thickening, and the patient might complain of pain on the left side with the probe, and this is obliterated POD. So you will see the bowel, the ovaries all attached, and very limited movement with the probe, and sometimes a lot of pain, especially with the top of the POD, which will indicate to us that he has severe disease, and how much of the bowel, if there's nodule on the bowel, whether it has infiltrated to the mucosa, where we have to think about resection, either discoid or segmental. So and more importantly, why we do the surgery? Is it for pain relief? It is for fertility? Is it for both? So all these factors must be taken into consideration when you're evaluating and when you're doing the ultrasound scan. So again, if I have to summarize what you are supposed to see in your systematic scan, you start with the uterus, and you try to see whether the uterus is mobile, tender, whether there is evidence of adenomyosis. All these have ultrasonic features which will help you to come to a diagnosis. And especially the antiflex, acute retroflex uterus, which less mobility will indicate that the POD is obliterated. And again, the ovaries, where they are, whether they are stuck in the POD, and whether they are mobile, tender, whether there is endometriomas present. And again, they have their own features, how to differentiate with endometrioma from a hemorrhagic cyst, or sometimes it's difficult. Hemorrhagic cysts are there, dermoid cysts are there. So how to do these things. And then you look at the bladder. The bladder nodules can be there, rare, but can happen, and you should not miss this because it's easily demonstrable. And the vaginal nodule. So the vagina usually sees from the ultrasound scan by as a hypoechoic layer. And then if you see a hypoechoic nodule, then you can see, and then usually it's easily demonstrable because of the pain the patient might feel. And then the POD, the obliteration, adhesions, the bowel, whether the POD can be moved very easily against the cervix and the vagina. And if it is not there, then you know we are going to deal with a difficult case, and what extent that the surgery has to be done. And the uterosacral nodules, bowel nodules, if you see bowel involvement, as I told you earlier, to see the dimension, how far is from the anus, what are the other structures attached to it, and what layers involved is a must. And then don't forget the kidneys, because when you do the transabdominal scan, if you see you may not be trained to do kidney scans, but if you can see the pelvic calyceal system dilatation, and then it will prompt you to go for a proper assessment by a urologist, which might indicate that there is hydronephrosis due to ureteric involvement. So we have to do the stenting and do a more extensive surgery. Thank you very much.
Thank you for that very interesting presentation on things that are not usually seen by people. Can I just ask you one question? You talked about bowel endometriosis now and then detecting it. Does it require any bowel preparation to do that, or is it would it help if you do a bowel preparation?
It's certainly like when I do the surgeries, I usually prepare the bowel in anticipating a possible damage if we see the bowel involvement, because the surgeon will, otherwise there is a possibility of end up with a colostomy because if the bowel is dirty. So in that context, a clean something to clear the bowel before the surgery will help. And also sometimes I've seen when you prepare the bowel are more collapsed, so it will be easy for us to perform the surgery rather than distended bowel. Sometimes it depends. So I usually prepare the bowels before the surgery in anticipating of a possible bowel damage, especially when you thinking of rectal shaving and all that, or when we ask the colorectal surgeon to help us, they usually require bowel preparations.
So thank you very much again, Prabodhana. So we will now go into a advertisers break and then move into the next segment of our webinar.
Ladies and gentlemen, we have now arrived at Bandara International Airport, Katanayaka. We wish you a pleasant stay in Sri Lanka.
So welcome back. And so now we're going to move into a very interesting part of today's proceedings, and that is we're going to have a symposium on the approach to the obliterated cul-de-sac from different perspectives. We have 5 surgeons who are specializing in this area who will speak to us and share their experiences on how to approach the cul-de-sac. Of course, we're going to have quite a bit of overlap, but then that's to be expected in this kind of approach to this very difficult problem. And let us learn from all these repetitions if you want, but I'm sure this is the best approach for this. So let's move into this symposium. And for us to start off, we will have Dr. Shamita Katurusinghe, who is practicing in Melbourne. I'm waiting for her CV to come up, but let's look at the advertisers notices first. So welcome back. It's my pleasure to invite Dr. Shami Katuru-Singha, who completed her specialist OBGYN training in the Royal Women's Hospital in Melbourne, in Australia. And she obtained the fellowship of the Australian and New Zealand College of OBGYN. She obtained a 2-year advanced laparoscopic gynae fellowship at the Royal Women's Hospital in Melbourne. And she's a senior clinical fellow she was a senior clinical fellow for endometriosis and advanced minimal access surgery at Oxford in the UK, and in the referral center there, which is the largest referral center in the UK for endometriosis. And she's concentrated subsequently on bowel endometriosis surgery by working with international expert Professor Horace Roman in France. So it's a pleasure to invite Shamita to share her experience. Shamita, it's all yours. Thank you. Thank you.
Thank you, Professor Hemanta Senanayake, and for the team for this lovely invitation to be part of this excellent webinar focusing on a disease that's really impacting a significant proportion of women. I'm going to start sharing my screen. Bear with me for 1 second. Fabulous. Okay, so my approach to the cul-de-sac, which is the topic today that we're talking about, actually starts with the pre-surgical workup. Obviously the assessing the symptom severity and the organ system involvement is really, really important. And in our centre, we work up the patient towards surgery by ensuring that patients' health concerns are completely assessed. We assess for a number of things such as central sensitization, we diagnose and manage myofascial pain, we optimize their pain management, and we carefully counsel the patient for their planned procedure. I say that because it's really important to plan your surgical approach according to your patient. We spend a lot of time in our centre to understand what our patients' quality of life goals are and what their surgical expectations also are, so that we can tailor the surgery accordingly. Some patients may want the anatomy normalised, but may not want the removal of any bowel endometriosis. And we take it, we make it a priority to provide the education, the counselling, everything that is required for our patients to make that informed decision making. But we ultimately respect the patient's autonomy. And even though we are surgically skilled to plan, do the extensive surgery, we try and hold back and do what's right for the patient. Now, when what I'm going to do is I'm going to spend the next few slides just going through the sort of my approach, and then we'll go into the surgical video, and then I'll discuss that, the surgical video. When we go in for surgery, when we put the camera in, what we want to do is take the time to map out the lesions. We don't really want to leave any disease behind. But at the same time, we don't want to do unnecessary dissections or remove unnecessary tissue that should otherwise not be removed. So it's really important to take a minute to map out the lesions. As you can appreciate with endometriosis surgery and other complex surgeries that you do, the tissue can sometimes be very inflamed and it can be friable. And therefore, once we start operating, we may fail to recognize previously seen endometriosis. And as you know, research is telling us, the patient's first surgery is probably their best chance of, having excellent outcomes. So you want to do a really good operation, and you want to hope that that's going to be the only operation that the patient will need for, for the foreseeable future. So it's really good practice to map out before you start so you can ensure complete excision of lesions. Now, as you're mapping out your lesions, what's really important to figure out is triage which organs are at risk of injury and what are you going to do to avoid it. The previous speaker, Dr. Prabodh, spoke about the use of ultrasound technology, MRI, which we may have the luxury of organising before the surgery, and that can definitely guide the surgical approach and even map out those lesions. So you do have that opportunity to plan ahead. And even if it's not the case, sometimes we walk into a surgery that we do, sometimes we unexpectedly find pathology. But once you do that, your diagnostic laparoscopic component of your operative lab, take a minute to think about which organs are at particular risk and what you can do to prevent it or reduce that risk. For example, if there's quite severe disease around your ureters and you think ureteric catheterization would be important, think about putting that in. Think about bowel manipulation if you're going to need a bowel probe to manipulate your bowel. Think about whether, for our centres, we're very fortunate enough that we can call on our colorectal colleagues. If that call needs to be given early, make sure you do that. You do that. If you think that you're going to be clipping any vessels that might be in your way, think about that. Make sure all the equipment is ready, and just kind of plan ahead. Think about the pelvic nerves that might be in that territory that you're going to dissect. Think about whether you're going to, how are you going to balance the dissecting out the pelvic nerves versus not dissecting it, but being aware and still being able to getting around those nerves to get the disease that you need to take out. Because as you know, you've probably known in your own experience, if you sort of manipulate any of your pelvic nerves, patients can go into bladder retention, they can have any other, certain complications. So you want to minimize all those things. As you sort of go through your surgical career, what you will want to do is to be minimalistic about the impact to nearby organs and services. Think about, can I avoid doing a complete ureterolysis? How much of the ureter do I actually need to see? The reasons behind that is that, as you know, the blood supply to the ureter, there's the anterior and the posterior, and as you dissect more and more, you're increasing the risk of causing a vascular injury to the ureter, and at the time of the surgery, you also increase the risk of having a direct injury or a thermal injury to the ureter. So dissect the components out that you need, that will assist you, but leave the other parts alone if you can. And remember, sometimes you might need to come back for a subsequent surgery. And it is so much more difficult to dissect in areas that have already had scarring due to previous surgery. So whatever tissue that you can leave untouched, it is in your best interest and your patient's in best interest to do so. Another thing that I'm trying to get better at is trying to minimize the handling of the ovaries as much as possible. If you really think about it, we can be quite brutal in the way that we handle ovaries, and it is it's a vital organ, and I can't think of any other organ that we would be so brutal with. So I'm always now thinking about, do I need to dissect? Do I need to, how much of this dissecting am I doing? Do I really need to suture this ovary out of the way? Can I minimize the impact but still get an adequate exposure so I'm performing safe surgery? And again, I've mentioned to you about minimizing pelvic injury. I say this to all my registrars and my fellows: think before you cut, and it is okay to double check. Sometimes there is that, you'll have that thought process going in your brain, is this okay? When your brain says, is this okay? It's probably that point where you stop and you check. And use everyone in your theatre, your scrub nurse that's experienced, your fellows that might be operating with you, do it collaboratively, because when we all work together, we'll minimize injuries to the patient. Now, we're going to move on to the surgical media. Now, I've really endeavoured to find a simple patch of double-cliss obliteration so that it is easy to follow for the novice surgeons amongst us today. and especially doctors that are training and are joining in our webinar. And I've done that so that as the speakers, for the speakers that follow, will build onto it so that we can consolidate our knowledge together. So I'm going to stop sharing this screen and start sharing the surgical video screen. Now, I want to thank my lovely new fellow, Dr. Lucky, for editing and labeling this video. So we start off with, there are some spelling mistakes, even though we've recognized that it was really difficult to fix it. So just making sure you're all awake and watching. So this is what we're doing. First is mapping out, plan your surgery. Take a minute to look at everything. What is happening? What's the bowel doing? Where are the endometriosis lesions? Where are the ureters in relation to that? Where's that hypogastric nerve that Dr. Silva was talking about in his anatomy lecture? How, look at the level of, look where the bowel is, look at where the rectum's coming up towards the uterus. Have a look at whether there's any bowel endometriosis lesions on the bowel. Look at the bladder. That's the vesicouterine space, and the spaces reches or the retropubic space is above, and map that disease there. And then once you're ready, once you know what you're going to do, put your ports in, the ports that you're comfortable with operating with, and that can be different for everyone. I usually do an left ipsilateral approach. I don't put all my ports in until I've mapped out the disease, because sometimes the disease might need me to have different configurations. And then I talk about access. And I'm using a harmonic scalpel here. You get the access that you need to get the surgery done. And this is just dissecting along the congenital line to line to tortuous to get the congenital bowel out of the way. Now, with using I've got two energy sources here. I've got the harmonic scalpel there, I've got a bipolar there. And I must say, I think this video is in 2009, and I think Dr. Arambagay is actually operating with me, assisting and supervising me during this surgery. So be careful when you use two energy sources, because sometimes when things are complicated, you might press the wrong button and you can cause injury. As you can see, I am using a bipolar to touch the bowel, but I'm being very conscious of the fact that I am doing that. So we're doing ureterolysis here. We're identifying the ureters. You can see how we're dissecting the ureters out. We're on the right ureter here. And I use the tip of this bipolar tip forward, pointing away from the ureter. So the point in, I'll show you. So not that way, this way away, to dissect along the ureter. So it's that push and spread, and turn the tip away and along to get to that dissection planes that you want. And you can see the ureter demonstrated there. And then next time, dissecting the ovary out of the way, and you can see this is something I don't appreciate, I try and avoid as much, because once that endometrioma leaks and then we start washing and irrigation, it really impacts our surgical planes. The funny thing happening here is at Oxford is that our senior scrub nurse has gone to answer a phone call, and has just come back, and she's instrumenting the uterus while we're proceeding with the operation. Time is precious. We've got a big list, so we keep going as long as you know what your comfort zone is. And while I was doing my fellowship, I really wanted to push myself with less than ideal standards, so that I was able to kind of then, be comfortable operating in difficult situations. So next, we're opening up that pararectal space, and we're opening the pararectal space below the ureter. So it's the And we're going to dissect away the hypogastric nerves because, as you can see, there's a big nodule there on the right uterosacral that we want to take out. I think we're going on to another video there. There's some dissection that's already happened. Now, as you can appreciate there, you've got the external iliacs. You've got the ureter dissected. You've got a partial parectal space opened up, and that's the bowel going, that's the rectum going up. And you can appreciate the ureter, so I'll pause that at there. So we've performed a ureterolysis. You can see the hypogastric nerves. The splanching nerves will be coming in. That's the right uterosacral ligament there, rectum, and then beyond it would be the sacropromontory. And this is the left parectal space, which is not completely open because there's quite a big lesion here in the left parectal space that we need to get through. These are your iliac vessels, and then this is your ureter coming through. Just going through the anatomy there again. You can see the nerve fibers beautifully displayed here. You can see the ureter vermiculating here. You can the same on the other side there. Now, this patient didn't have any big endonodules, very close to the sort of the rectum, but there was a really superficial sort of lesion of endometriosis down there, and we've kept that video in just to show just the really basics of like a really simple sort of what we're trying to do with shaving. Because I'm sure the next speakers will, probably go into further more detail. So this is excising more of the endometriosis. So you can see uterosacral ligament, we're in between that space, and the bowel and the rectum's just behind here. Cervix, posterior cervix for uterus is just above us. And here I'm using a monopolar spade. Checking, double checking, making sure that we're not in harm's way, because unfortunately, practicing medicine in Australia means litigation risk is very, very high. I use bipolar for, especially around the fatty areas, for hemostasis. In terms of bowel shaving, I would use, a combination of cold scissors, monopolar spade, harmonic scalpel. If we're doing a discoid resection or a bowel resection, we'd probably still use the harmonic scalpel to kind of, prepare the bowel. In my training, the combination of supervisors I've had, they've used combination of energy sources, and it's what you're comfortable with. If you have colorectal surgeons, especially in our public centre, when they come in, they're a little bit hesitant, depending on the colorectal, to use any electricity, and that's completely respected. And you can appreciate here the rectovaginal space, and you can see now the rectum is actually, the anatomy is normalised, and you can see that now we can actually see the space has been demonstrated. And all that endometriosis has been sort of, excised. Just getting some hemostasis happening. You can see you can do a quick bipolar buzz and come out. And there you can really appreciate the anatomy. So now rectum has been, it's mobilized, rectovaginal space is full in display. You can see the level of dissection that's been required for this patient who's had quite extensive disease. Now, you can see that little superficial spot of endo there, very superficial spot. This patient had extensive symptoms, including sort of diarrhea, dyschezia, bloating and nausea. We're just putting a rectal probe just to kind of get to that area. It's a very superficial disease. I'm just using the spade to initially just to open up that space, and you'll see the exposure of the fibers. I think for this case, we hadn't opened up the harmonic, and I'd done the whole case with the spade, so I'd probably just continued. So coming off the tissue, just really just quickly get into that plane. Yeah. And then I would have, can see the fibers exposing now. It's very superficial disease. Just get the scissors. Trim that really superficial lesion across. And then if you're in any way worried, you can always put a suture over it. I think in this patient, we did put a suture over it. That's what it looks when it's trimmed out. And I just use a 2O J333 Vicryl. And the intention of the suture is to kind of bury that raw area. And it's a balance between just picking up enough tissue so that you're not ripping your suture through. Just move on. So majority of the time we don't, even if majority of the time we don't actually, I don't actually suture, but this particular patient is another doctor. So therefore I have this theory that when I'm ever operating, and I operate on a lot of medical colleagues, when I'm operating on medical colleagues, I'm a little bit more careful because I just think we just have the worst luck when it comes to complications. So just to suture, just to over sew. And then, once all the other dissections are done, that's only when I kind of deal with the ovaries if there's any nexa. And then as I finish the case, we're just checking the bowel integrity. So we're filling up the pelvis with some fluid, blocking the bowel, and then just pumping some air just to see if there's any leaking of air. That looked fine. And then if I've got no concerns of any other concerns, we use hemostatic material, and I use anti-adhesion barrier just to prevent any adhesions. I know that the Cochrane review in terms of risk-benefit is low, but in my personal practice, I've found that when we go back in for second stage ops, the pelvis looks pretty spectacular with the use of these. And before we put it in, we try and minimize everything. This is just an example of what kissing ovaries would look like. And you can see there's a nodule stuck out behind. In this setting, I do an oophoreplexy to get exposure, and then I deal with the pathology at hand. I'm going to stop sharing that screen and just get to the last few slides in my talk.
Shanta, you got 2 more minutes, please. Yeah. Thanks. Thank you. Thank you.
So we've gone through the surgical video, and my motto is less is more. Don't overexpose, don't over dissect, don't over excise, and think about your patient when you and as to why you're doing everything. And I just want to say thank you for the opportunity. Have a good evening.
For that. Thank you very much, Amita. Thank you for that interesting talk and sharing your experiences. And if there are questions, we will take those at the end of the session. Please keep the questions coming in. Thank you. And so we're going to move into the next speaker. But before that, the usual advertising break. And we'll be with you soon.
අපි කාගෙත් කැමැත්ත සුවසේ ජීවත් වෙන්නයි. හැබැයි අසනීප කියන දේවල් කියලා එන්නේ නෑනේ. ඒ වෙලාවට ලෙන්ගතු සිනාවක් කියන්නෙත් දිවවුසුවක්. ඒකයි මිල්ස්ටා හොස්පිටල් ශ්‍රාගම මේ තරම් සුවිශේෂී. විශ්වාසය අංක 1. කවුරුත් දන්න මෙල්ස්ටා සමූහයේ සවිමත් පදනම නිසා හිතට බයක් නෑ. ඒ විතරක් නෙවෙයි. ඉහළම ප්‍රමිති සහතිකවලින් පිදුම් ලබලා තියෙන්නේ සේවාවන්ගේ ගුණාත්මක බව නිසා. පේනවනේ. හරියට ජීවිතේ අලුතෙන් පටන් ගත්තා වගේ. ඉහළම සත්කාරය විතරක් නෙවෙයි. ඉහළම තාක්ෂණය සමග පළපුරුදු වෘත්තිකයන් අතින් තමයි සියලුම සේවාවන් ලබා දෙන්නේ. අපි එක පවුලක් වගේ. හැමදාමත් ඔබ වෙනුවෙන් අපි ඉඩක් වෙන් කරලයි තියෙන්නේ. ඒ අපේ එකම නිසයි තරඟකාරී අඩුම පිරිවැයකින් සේවාවන් ලබා දෙන්නේ. හැමදාමත් අපේ සබැඳියාවේ මුල් තැන ඔබයි. මෙල්ස්ටා හොස්පිටල්ස් රාගම. සුවවත් සවිමත් සබැඳියාවක්.
So it's a great pleasure to welcome my friend Amphan, who is a leading pioneer gynecologic laparoscopist in Thailand. After a 2-year clinical fellowship training in Germany, he was awarded the diploma of the Thai Subspecialty Board for Reproductive Medicine, and that's from the Thai Royal College of Obstetricians and Gynecologists. He's been a board member of the Thai Society of Gynecologic Endoscopists, and he's very, very active in teaching. He's conducted over 100 gynecologic endoscopic workshops in Thailand. He's an international board member of the Asia Pacific Association for Gynecologic Endoscopy and Minimal Invasive Surgery, that is APAGE, and Asia Pacific Gynecological Endoscopic Training Group, and the Thai Society of Endometriosis and Adenomyosis. He's the current president of the Thai Society of Gynecologic Endoscopists and the director of the Thai-German Multidisciplinary Endoscopy Training Center. That's in the division of endoscopy in the Department of OBGYN in the Siriraj Hospital, Mahidol University in Bangkok, Thailand. I know that Amphan conducts a lot of cadaveric anatomy workshops as well. So Amphan, thank you for coming on board for this. It's all yours now. Thank you.
Okay, thank you so much, Samantha. and also for your kind introduction and also invitation me to join in this special event. This is my hospital. It's the west bank of the Chapaya River center of Bangkok. So today the scope of I talk it will be pure.
Amphan, just to interrupt you for a moment, it's better if you go on the full screen mode. That is, go to the, yeah, that's fine. You forgot to do that. Thank you.
Sorry. So we will talk about the preoperative approach and also surgical approach. And also I will present a two-video presentation today and also summarize the step of this section. So as we know that endometriosis is very common for the operation operated of cordyceps, especially in the case of severe, and also the more difficult surgery that for the diagnostic surgeon. So, and we know that mostly undiagnosed prior surgery, we just go in and see and make it. And sometimes it's got a problem, many things. So the diagnosis for the operated cordyceps before we go in maybe is better. So what is that I commonly found what is got operated of cordyceps? Usually is we can find in the recurrent after a previous open surgery case, actually in the endometriosis, or also before like a myomectomy. And also in the long run, obviously, of severe symptom of endometriosis, or we got a suspected of genital pathology and also symptom. And in case like multiple myoma with endometriosis, or also adenomyosis with endometriosis, and also in case that bilateral ovarian cyst, and also the common one that I found is a post multiple cause of ovarian put-up. Through history tracking and periodic examination, and also preoperative workups to diagnose prior entering the operative room, it maybe help us for the more proper preoperative and also surgical approach. So the preoperative approach, in case that we think suspected in case of operated cordyceps, so we can keep more appropriate for the patient counselings, and also we have to adjust our skill. This is we can do or not, or we have to refer to other surgeon. Also, we have to ensure that we have an appropriate surgical team and also equipment, what we like to use, and also what the one that I like to consider is the preoperative medication. Regarding the preoperative medication, I think we know that now we have no evidence to benefit of preoperative medication for the outcome of surgery by X-ray and anything else from many guidelines. But okay, we use many cases in the severe symptom and also in suspected severe pathology case, especially a few months of preoperative medication in our center. My choice, usually I use 3 months of GNS analogs or maybe just over-the-counter oil pills. And with my long experience of preoperative medication, I like to suppose that it's quite got a benefit, and I'm happy to use in many cases that we think that is severe endometriosis case, because I found that it can reduce the inflammation and also vascularization of the lesion. And also we can, when we working, we can reduce blood loss, reduce time of the hydrourethral, ovarian cyst, and also the coincidental finding like a myoma or adenomyosis. So I think it can more successful for conservative surgical treatment. So as I showed you, this one is the case that no preoperative medication that I found. So it's quite severe. Sometimes we got a severe bleeding. It's a lot in the pelvic cavity. So when we just touch or something like that, it's kind of bleeding, and so it's make more bleeding during surgery. But we compare with the preoperative medication in this picture, can found that is nice. And so if we someone told that is we might be is a diminish the size of uh, the lesion, but actually we have to know the lesion of the endometriosis, both of a fresh lesion or heal lesion or something. In this case, I just like to show you in the same patient between preoperative medication. In this case, refer case, and they do just a diagnostic laparoscopy and see the hydrosol pink, the big one, and they cannot do more, just refer to me. And when I found that this case is a severe case, so I just give her 3 months of Jameson, and that one we found, and we can keep her tube. I'm not sure the function of tube, but the tube is patent after we make a perturbation is positive dye. So we try to keep for her because Thai people is not easy also to manage. Is quite got a financial problem to get a ART program or something. So in my key point for the approach of the operated cul-de-sac, so what we have to stress or focus and should remind every time, that means we should optimize exposure, like we use unique later, and also usually we also do orient suspension, and also the additional part of the trocar for the assistant is very necessary in difficult case. And also don't forget to perform the easy step first, the area that easy. It will first facilitate to difficult one. Sometimes we try to jump to the difficult area, the severe adhesion area, and it's make more difficulty and bleeding. So don't forget this one is very important. And also divide adhesion and restoration to anatomy. We have to restoration anatomy. Just remind what is the normal anatomy. It's very important. Because for the new surgeon is always forget to remind by themselves that which one is the normal anatomy, and also just remind that the fat is belonging bowel and bladder, not from uterus, but fat is not bowel and bladder wall. That is because when we dissection and we get a fat, we just afraid that it will be a wall, so not afraid. But when we dissection, we know that when we get a fat pain, that is the safety pain. So it's the same that when we have to free and isolate the lesion, that is start the dissection, that is a lesion-free area or the adhesion-free area, and also the aim, like Shamik said, that is we should have complete excision as much as possible, but we just careful is not too much. But for me, I think when the endometriosis lesion is like a root of the trees, so it's got a tap root and also capillary root and something like that, a small root. So it's sometimes it's like iceberg. So we have to careful and try to excite as much as possible. Otherwise, we can let the lesion in the patient just careful and see how we can do that. And also what I like to suggest, that is my point and my key. That means I perform with a fine dissection manner. It's very important to minimize the nearby vital organ injuries. What I prefer, I use a blunt bipolar system and also the blunting of suction and also just scissor. Actually, I never use like a harmonic and also the sharp end or maybe from the other instrument that is sharp end. I don't like it. Like a Maryland or something that is too sharp. And when we dissection, maybe in entry appropriate the vital organ. Complete hemostasis is very important, very short low energy activation. That is will result the fever char and also a lower lateral tumor. And sure, as a Shamit, that in anti-adhesive barrier is very, very important, especially in case that ovulated cardiacs. Because after utilizing adhesion, you have to cover the uterus, protect adhesion, recurrent from bowel adhesion, especially in the posterior part compartment of the pelvic cavity. So let me show a 3 videos today. Each one is about 8 minutes. I try to edit to proper the time that you give me to present. So this one is the end block butterfly excision. Is a case from conservative surgery, the one that need to get pregnant in the future. And also what we try to do is just restoration anatomy. We mobilize the ovary first and also dissect the obliteration of the cardiacs at the posterior part of the uterus. So when we see the cyst, endometric cyst, to make sure that you have to reduce the size and also do a cystectomy. The cystectomy usually, when I after do that, I will reform the ovary almost every case with the bullet technique. Close the egg, not to expose the outside, and also make the wooden suspension both sides to expose the area that we want to do. So we come entry the retroperitoneal space and make sure that we have to identify ureter and also entry the space. We make a boundary of the area that we have to excite, something like this. And also we excite as an end block technique. Yeah, actually I use just only a blunt bipolar and also scissor and also suction. I don't support to use mechanical cutting from the advanced bipolar because you have no sense of the disease, how hard of the tissue that you cut it. Sometimes when we cut it and we know that it's not enough, we have to deeper cut to get a deeper cut to get more of the disease. You can see the disease inside. Don't forget the space that our colleague talked. especially Opatayati and also Lescote space and also paralectal space, the medial paralectal space, and also rectovaginal space. You can see the disease that the feeling when we touch it, we know that there is the end of the lesion. Come to the right side, this is the demarcation that we to excite. When we open the rectoperitoneal space, go to jump in, we can just small perforation and just cut the peritoneum, just the parallel of the ureter, just a thin area, and we come in and identify the ureter. So when we cut it, we can coact and cut deeper. Just careful a vein, uterine vein that's coming with the lesion. The cervical part is very common for the DAE. So usually it will involve with the lesion. So you just blunt dissection is no problem. Blunt is not injury to penetrate the bowel or perforation. So this one is just for the conservative surgery. Okay, let's show another one is for the TLH. You can see that many cases when you saw that it's very, very clean because most of them is already got a perioperative medication. So we entry the rectoperitoneal space and try to see find out the ureter. entry and see the ureter. Can see the ureter now. Suction is quite a good instrument for the dissection because it can suction the blood and make our operative field is clean. You can see that we can coagulation with the very short activation. You can see that we don't know where is a ureter, but you can open the peritoneum and go in the retroperitoneal space and you dissect along the way of the ureter should be with a blunt dissection. You can see some like a organ, the long organ like a vessel or ureter, and you can touch and see the peritonitis. This one got a light audiences. Usually I do not divide or restoration only from the uterus if I like to sapingoophorectomy in that side. So we keep it together, make it like an end block. Just end of suction. With a blunt tip and very strong, powerful, you can dissect and can clamp and traction with this instrument. So now we try to dissect the ureter and also excite the region that include a segmental part of uterine artery out of the ureter. One of difficult case will be operative cul-de-sac with myoma or large adenomyosis. So we cannot approach the posterior part. So sometimes we have to excise entry the vagina first and then retrograde. Actually, vaginal closure and we do at least 2 layers. The first layer with the white cube and the second layer is the V-lock. Okay, I think the last one. This one is quite interesting. She when ovum picked up 2 times, and before she got just a small cystic mass at the left ovary. Diagnosis is lymphatic cyst at the left ovary, just 3 centimeters. But after 2 times of ovum picked up, she developed the cyst is bigger, and she got a severe pelvic pain, and also her dysmenorrhea is cannot solve with the medication. So she underwent to open surgery, and the surgeon cannot do because of severe adhesion. So just a cross, and after don't do anything, but she cannot. So she come to see me. So what we will do that we found a cyst under the rectum. So what we see when we see fat of the bowel, you don't have fat of bowel, but you just see that it's no bowel wall. So she would have abscess, tubal and compact infection. So in this case also, I thinking that she got it is a severe case, so I give her for the preoperative medication, and also preoperative counseling is for the radical surgery. And also she agreed because she even underwent to open and cannot work. You can see the adhesion is attached to the pelvic side wall. Can see iliac vein and iliac vessel. We try to excite the disease from the vein, external iliac vein. So now we try to entry retrograde space separate between IP ligament and also ureter. But what we found is not ureter, is internal iliac artery. But firstly, I think it's ureter. Just careful and dissect the adhesion part.
I'm sorry to interrupt you. You got only 2 more minutes, please.
Okay, thank you so much. So we will leave this one. So I like to summarize the step of this section. So if we got a momentum unbound, we should mobilize from the pelvic side or wall side to export the annexal structure, and also myelite annexa from the ovarian fossa, and also maybe adhesion with the ureteric ligament, posterior wall of uterus, and also bowel to improve the view of operative field, and also suture. Almost every time I use when it comes to suturing with a body edge, and also oropexy, and also enter the retrograde space between pelvic triangle if we pelvic triangle if in case of ovulation, and also IP and ureter, 25 ureter first see the peritonitis movement, and also perform uterolysis. Open the lateral parietal space and also medial parietal space. Usually endometriosis is also adhesion with the ureteric ligament, so we have to do more ovarian space to open more than last one. And also identify ureter, and sometimes we have to go ahead and cut it. So for the rectum is just a posterior wall of uterus entering the rectovaginal space by open with both of parietal space and go down and join together at the distal part. I think we would know and complete excision the region, and also don't forget to use anti-adhesive agents. So by my conclusion is for my approach of the operated cardiac sex is we need a proper preoperative and surgical approach. Usually I use a treatment of GnRH analogs, and also we have to got a surgical skill and also got a anatomy knowledge, and also we try to optimize the exposure that we can do, and also instrument my tip is a blunt tip, bipolar suction and scissor, and also don't forget the antiseptic adhesion. Adhesion agent usually is we use antioxidant, regenerate cellulose, also intercedes at shimmer. So don't forget, I'd like to cordially invite you to attend our hybrid workshop on 3rd to 5th of March of 2021. And we got a world-class speaker like a Masaki, Chineban, and also Lalam, and also Postware. Please visit our website, tgmed.in.th. This one registration, and also this is a free registration, and hope and see you all in this forthcoming workshop. So thank you so much.
And thank you for those really illustrated talks, and you showed that with appropriate skills, what cannot be done in an open surgery can be done laparoscopically. So thanks very much for again, and we'll take the questions at the end of the webinar.
Thank you.
Thank you once again, and we're going to the advertising break, and then we'll be back again with Dr. Dhammika Silva's presentation. Thank you. Thank you. So we have our colleague, Dr. Tamika Silva again. He's been engaged in advanced laparoscopic surgical procedures for some time. He is the leading gynecological endoscopist in our country. So Tamika, we look forward to your talk. Thanks very much.
Thank you, sir, for that kind introduction. One of the, maybe not the lead-in, sir. Thank you. I'll just share my screen. Right. So when looking at, I saw this few days ago, could not resist not putting it because this looks so much like the laparoscopic surgery we do. The Ricardo, but the focus of and eyes on the target, avoid all players. So it sort of shows exactly, looks like laparoscopy to me. Pure focus needs a lot of fitness and health to do long surgeries. He hits a target, avoids everything around him, the other players and everything, puts the ball right where it's necessary, and he doesn't hurt himself. So, it looks quite a lot like laparoscopy to me. Well, if you look at the approach to the cul-de-sac, basically all of endometriosis, we have the round ligaments, we have the tubes, we have the ovaries. The two ureters on the side and the uterosacral ligaments, the two hypogastric and the bowel, and endometriosis everywhere. So basically what we need to do is it's excision of whatever we can, or total removal of almost all the deposits we can. Of course, we are going to leave some behind. And this is the basis of endometriosis surgery. So all the structures which I showed needs to be preserved. The tubes, the ovarian ligaments, the ovaries, the ureters, the uterosacrals, as much as possible, the hypogastrics and the bowel. And that should be the basis of our surgery and the approach. Now, initially, I'll just list out the surgical steps quickly. The first is, of course, getting access to the cul-de-sac. So basically, first of all, what we need to do, the first thing we need to do is to try, if it is there, to free the ovaries and free the tubes. And then probably because we need access, it's better to suspend the ovaries from the anterior abdominal wall. So I'm going to just go quickly on this video since it's time for it. So this is the adenolysis happening and the ovaries are getting freed. And the next step, of course, is because our work is down there in the pelvis. So therefore, once the adenolysis of the ovaries is done and once cystectomy done, and if necessary, finish off the ovarian part, the cystectomy, everything, and then get the ovaries out of the way because we are the major part will be in the cul-de-sac. So this is what I normally employ. You can see that in this patient, I think about 4 or 5 surgeries have been done earlier, and the problem is infertility. So first is get the ovary and finish it off if possible, and then hang it so that you have access. The second step is approach the pelvis. Now, the two sides are different. What you're looking at is the left side of the pelvis. this is the doorway to the pelvis on the left side. You dissect the sigmoid colon, you come really up near to the brim of the pelvis, even higher, and then only you open into the pelvis. So whatever is stuck down there, whatever the obliterator the sac is, the best approach to the pelvis without harming the bowel is on the left side and through quite high up. So you go high up and then you slowly start dissecting. We are looking at the left side of the pelvis where the rectosigmoid is, where most of the lower down, most of the endometriosis is located, because the right side of the pelvis is fairly free because the rectosigmoid is not there. So that is the approach. You can see this is the approach to the left side. You can see how the dissection goes on, and slowly the bowel is lateralized, and that is how we get access to the pelvis. Here, slowly, I am forwarding this video a bit. You can see that is the ureter, and then that is also safe, and you go on the pararectal spaces to gain access deep into the pelvis by dissecting along that. So you see, that is the second part, right? The next one is also about access. If we are working in the pelvis for any surgery, and sometimes the bowel gets in the way. So if you want to really get most of the bowel out of the way, you can see that this is possible. There are different gadgets which we can do it, but you just get the appendices of epiploidy threaded onto a straight needle, which is probably the cheapest way to do it. And then you can pull the bowel out of the way, which I'm going to show you. And you can see that it is hung onto any wall, maybe the left or the right, wherever you want to get access to. And this can be done. So it's pulled by a thread over the abdomen, and then of course the access becomes far. You can see it's been pulled. And here we will now gain a view of the pelvis. You see the bowel is completely out of the way, and then you have good access for your dissections. So the third thing is to get the bowel out of the way. So if necessary only, so that you have good access. Otherwise, you'll have to use an assistant to do that. Then earlier, as I said, the sigmoid colon dissection, which I'm going to go very quickly. It's the same thing. So if we need to get onto the left side of the pelvis, always try to dissect along the pararectal spaces so that we will get access. Right. The next step is ureterolysis. So the left and the right ureters needs to be dissected, because we need to, when we exercise endometriosis of the cul-de-sac, our ureters must be clear right up to the point where it turns away from the bowel. So usually there is very little endometriosis beyond the point where the uterine arteries cross the ureter. So it's best to do the ureterolysis right up to that point, or at least at the places where it is necessary. Then we have to do the pararectal spaces, so the lateral margin of the bowel and the hypogastric nerves are clear, and the uterosacral is in the middle. And therefore, once you have done all that, then we can excise all the endometrial tissue, because we know exactly where our most important structures are. So this is left ureterolysis. This is the left side of the pelvis, which you are going, you can see. And you can see the ureter here. You can see the ureter here. You can see the ureter there. I'm just touching. And this is the uterolysis, which is going on. So already the pararectal spaces have been dissected. So that you can see the ureter now clearly right up to where the uterine artery crosses. And this is the left side of the pelvis. Sorry, and this is the right side of the pelvis. So the next step is of course the uterolysis, right? Then the next what we have is the pararectal dissection. So both pararectal spaces need to be dissected so that the bowel wall is very clear on both sides. So what happens? This is the left side of the pelvis where you can dissect the long side and the pararectal space is opened up on the left side. And the next step would be to go on the right side and open the pararectal space, and then to meet in the middle under the uterosacral arch, right? And where we dissect into the rectovaginal septum, and then the whole bowel comes down. So next step is the rectovaginal septum dissection, which I said. So you see both pararectal spaces have been dissected. So therefore now the next step is just to meet under the uterosacral arch and bring the bowel down. So next is, I'm going into the pararectal space where the whole rectum is going to come down. Now it's attached to the uterosacral arch, and there now it's been brought down. So now we know exactly where the bowel is and where the upper wall of the bowel is. Right. So what do we do? Yes, if there is a rectal nodule in the cul-de-sac, once we have brought down the bowel, we can shave it. So it's just cold knife shaving. We have to be very careful. But if the bowel is very well prepared, it doesn't really matter if you open into the bowel. We can always put a stitch. And so this is a nodule that is shaved. Normally, if it is if the depth is less than 3 millimeters, we should be able to shave the bowel. Right. What else do we do? Yes, once the bowel is down there, we can always do a discoid resection with a stapler, where a circular stapler is put in and a discoid resection is done for the bowel. These are linear stapler, it's not a discoid actually, and then that also can be done. So this is what we can do. Next, this is also a rectal nodule. What do we do also? These are discoid resection with circular stapler, which I spoke about, where you can see the nodule there. A stapler is put inside. The nodule is invaginated, and when it's fired, a disc is cut off. So that's a circular stapler discoid resection on that. Right. And since all the anatomical landmarks are clear, the next step would be just to shave off the endometriosis. This is a severe case of endometriosis, but the dissection has been complete. Usually when you do endometriosis, most of it will be a bit reddish, but it will settle down later. So here the uterosacral nodules are being shaved off. Right. This is a vaginal nodule. So once we reach this anatomy, once the bowel is down, the uterosacrals are here, you can see. We can open it to the vagina, and through the vagina, if there's a vaginal nodule, we can cut it off. This is a vaginal nodule, which you can see is being cut off, because this gave this lady a huge amount of dyspareunia, and she could not have sexual intercourse due to this nodule. Once the vaginal nodule has been cut off, she had complete pain-free intercourse. There were no problems at all afterwards. Right. This is also what is done in the cul-de-sac, because it's so once the dissection is complete, since we see everything, you can see the ureters there moving. So ureterolysis has been, the bowel is down here, the rectovaginal septum is visible here, and then this is the rectovaginal space, and then the bowel or the nodules are cut off. This can only be achieved once complete dissection of the the bowel, the pararectal spaces, and the uterolysis have been done. Right. So if you look at I'll present some case scenarios. This patient came with severe sciatic pain. She was opioid dependent. It was so much of pain, she could not get off from a bed, and the MRI showed two large bowel nodules here on this side. So not bowel nodules, sorry. A huge nodule occupying the uterosacral region here, and a small nodule on the right side, and some sciatic infiltration with endometriosis. So if you can see, once you go into this pelvis, she's a young girl, 28 years old, and once you go into this pelvis, it appears as if nothing is wrong. But if you look very carefully, I'll show you, I will tell you. So following the same principles, you can see that the ovary is suspended to get good access to the cul-de-sac. That is the left side. She had a bit of, her uterus had adenomyosis, which you resected as well. Now, this is the point where, remember that we discussed the approach to the side of the pelvis. So this is the pararectal space. This girl needed a sciatic nerve dissection as well. It's going along the pararectal space. This is important because we need to know the bowel, where the bowel wall is actually. So you can see now, so the pararectal spaces on the left have been dissected, and you can see that the bowel, the nodule of the uterosacrals are there. So the left pararectal space has been dissected. So now the right pararectal space will be dissected. That is the approach to it, you can see. That is the, actually on the right side, you can see the nerve slightly, that is the hypogastric nerve here. You can see. And this is the pararectal space. So it's classically, you can see bowel wall, pararectal space, hypogastric nerve, and then the uterosacrals more laterally. So the next step now is to, the pararectal spaces have been dissected. Now we need to get the bowel down so that we are opening into the rectovaginal septum. Once that is done, then we can dissect the nodule without harming the bowel wall. So the next step now is to go into the rectovaginal septum, and now it has been opened up. Now the nodule is clear, but still the nodule cannot be dissected before a complete ureterolysis on the left side is done. So this is just the same patient where the bowel is being taken out of the way. I'm going to accelerate that a bit, sorry. Right. Now, here already the ureter has been dissected on the left. So we are looking at the left side, and this we are now what is being done is the whole nodule is getting dissected. So it's monopolar diatemy, and the whole nodule can be. So nodule, how do we recognize the borders? It's just by feeling. So that is the only way which you can do. When it becomes soft, we can stop. Otherwise, when it's not soft, then we have to dissect some more. But we have to be very careful. You can see the ureters on the left side has been dissected. So this is the right side uterosacral, and there's a nodule there as well. So that is so her pain from 10 out of 10 came down to almost 1 out of 10, and it slowly settled later on. And you can see the nodule where the blood or the old blood is coming out when the nodule is getting dissected. So this was she had complete, very good relief of her pain. She could go off opioids, and that was the first case. Right. Case scenario 2, this lady is a 29-year-old patient who had an endometrioma, adenomyosis, adenomyoma, a rectal nodule, and nodules in the uterosacral ligament. She was infertile, and she had dyspareunia, dysmenorrhea, dyschezia, and the main thing was infertility. So mainly, of course, we need to concentrate on the tube. So this is on the right side, ovarian cystectomy has to be performed. But since a lot of patients cannot afford IVF, we have to make sure that the tube is well looked after, so that we, so here the tube has been freed, it was buried underneath, and it's slowly resected. the most three important spaces is the space between the round ligament and the tube, within the tube and the ovary. So those spaces need to be treated very gently, and if there's endometriosis, they need to be resected. So this is a cystectomy done. This is vasopressin getting injected, and you can see that the wall of the cyst wall came out very nicely. And so then afterwards, a cystectomy is getting performed, and then once that is sorted, it will be suspended. So that is, so you can see that the right ovary is getting suspended, and then we will switch on to the left side. So you can see now that is the left ovary getting freed, and that is a small endometrioma. Now that is also sorted and it is suspended. So now what is left is bilateral ureterolysis, bilateral pararectal space dissection, rectovaginal septum dissection, and then the resection of all endometriosis that we can see. So here you can see that the ureterolysis is being performed, and now it's already done on the left side. You can see the ureter free, and this is the pararectal space being dissected, because we need to know where the bowel wall is. We need to know where the ureter is to excise the endometriosis of the, you can see the whole huge nodule here. You can see this is all nodule. So now the pararectal space administration, now it's joining them under the uterosacral arch. And that is, then once we open up, we open into the rectovaginal septum. That is the adenomyoma, which will be taken off later. And now, once everything is done, this is rectal shaving. So the rectal shaving is being completed by cold scissors. You can see the, and during this, if, so one of the good ways to pick up the nodule is to thread something through it, and then it's easier to lift it up while you shave it off. You can see that the nodule is there, and then nodule can be completely taken out. So this did not involve, so the nodule has been shaved off completely, but there was a opening into that, so a small stitch can be placed, over suturing can be done, so that that there won't be a leak. Later, a leak test needs to be performed if you do some suturing on the bowel. And then the rectovaginal nodules, you can see the uterosacral nodules being slowly taken off. So that is the complete excision. I don't know whether I have any more time. So do you have any more time, or have I? Right. So
you got 2 more minutes, Tamika.
Right, okay. So I'll just show this one. This is something I just wanted to emphasize. This is a patient who has severe endometriosis, and she undergoes a hysterectomy. Now, what I want, this is very severe adhesions. What I want everyone to understand is that the, sorry, this is 3, I'm sorry. Is something that this is all adenolysis, I'm going to skip, is that the approach to the 49-year-old patient, she had very severe pain. The approach to the cul-de-sac need not be exactly from below. We can approach the cul-de-sac from above, and that is where we do a retrograde hysterectomy. So if you see this, this is all obliterated. I'm going to skip this because I have only 2 minutes, and I will show you that the lateral approach to the cul-de-sac is possible. Now, here I am starting the hysterectomy from this side, and because the approach from below is difficult, And what's going to happen is, once we're still on the anterior sort of wall, I'm going to open into the vagina first, and then find the space between the vagina and the rectovaginal septum. Open the vagina in a retrograde manner. That can save us a lot of problems. Still the hysterectomy is going on, and I will just go to the point where the anterior opening is done, so that we can fall into the rectovaginal septum. Now this is the lateral side. I'm going to go some more. Right, now this is opening into the vagina, and this is the space which I spoke about. You see the space, this is the vagina, because we know the thickness of the vagina very well, and therefore we can easily open into the rectovaginal septum once when you are doing a retrograde hysterectomy for endometriosis. Now you see the space which is opening up, and that is something, the bladder here in this patient gave us a lot of trouble. You can see when you pull the cervix, and then we can, that is the space that I wanted to show. That's the space up there is the vagina, and that is the space which you are opening up. So the bowel will be safe when you go there, and when that space is dissected, then the retrograde hysterectomy becomes very, very feasible. And even if there's that is the rectovaginal space. So even if there's a lot of bowel adhesions down there, we can do a retrograde hysterectomy, open into this space, take the cervix off the vagina and surrounding, and then dissect the uterus off completely without harming the bowel. So that's all which I wanted to show in this case. I just show the last final sort of. Okay. So you can see the vagina has been sutured and the bowel is safe. So that's all I had. Thank you.
So thank you, Dhammika, for that well illustrated talk. As usual, it's very informative. Thank you very much. So now we will go for the endometriosis break, and followed by the talk by Professor Alexander Popov. Thank you. Thank you, Dhammika, again. Thank you.
As we all move forward, don't forget to get plenty of sunshine. Drink lots of water. Remember to really breathe. Stretch. Spend time with the people you love. Find your balance. Focus on the important things. Rest. Eat healthy. Laugh a lot. Soak it all in. And remember who we are. So strong, so resilient, so Sri Lanka.
For management of endometriosis, choose the gold standard. Prescribe number 1 GnRHA in its class, Lupride Depot. Preoperative treatment with Luprolide. Offers reduction in ovarian mass volume by 56% in 3 months, reduces non-menstrual pain score by 47%. Post-operative treatment with Luprolide. Delays the relapse of endometriosis symptoms. Reduces rate of symptom recurrence.
Okay, welcome back, and it's a great pleasure to welcome and to introduce Professor Alexander Popov, who is head of Department of Endoscopic Surgery in the Moscow Regional Scientific Research Institute. He's been in practice for more than 25 years and has published extensively, 360 or more, 3 monographs in cooperation with his colleagues, and he holds 5 invention patents in Russia. He's one of the authors of the Federal Endometriosis and Myoma Guidelines, and he has supervised over 30 PhD students. He's trained in leading centers in the world in endoscopic surgery, including the Mayo Clinic, University of Kiel, and in France. So, Alexander, it's a great pleasure to welcome you for this webinar. It's all yours. Thank you.
Thank you, my friend, to invite me to be here. It's a big pleasure to share my opinion, our opinion, how we do this very difficult kind of surgery. I start to show my slides. Okay, we are talking about approaches to the obliterated cul-de-sac and how we can do this very difficult procedure. I do this procedure myself from the beginner to the end. I don't invite in my operation room coloproctologist or urologist, and I do believe that this time when we have to talk about the preparation of new generation of surgeons, pelvic surgeons. And what is important thing, if you understand all speakers, previous speakers, we do the same procedure in case of deep endometriosis. And that is why we can call this technique right technique. Of course, we do the same steps during this procedure. And of course, we use special manipulators, uterus manipulators, a rectal probe during this procedure. I would like to show the video. Okay. Have you seen my video?
We are not seeing your video, not yet.
Okay, this is a very small set of instruments. We prefer to use 0 degree of laparoscope and
Alexander, just a moment. I think you need to share the screen.
Okay.
Yeah. We can see you, but we can't see your slides.
I stop my video.
So, yeah, we can only see you still.
Okay, good.
Oh, no, that's better. Thank you. That's fine. Great.
Now it's correct?
Yes, we can see your video. Yes.
Very simple set of instruments, including grasping atraumatic forceps, bowel forceps, and rectal probe. This picture shows us the place of trocars. It's different if you compare with a simple laparoscopic example in case of infertile women. it's up if you compare with the typical place of trocar. Of course, we use intrauterus manipulator. I prefer to use this type, Pelosi type of uterus manipulator. It gives me the possibility to change the position of uterus from to anterior position of uterus. It's very important to open post-gastrectomy space. First of all, I underlined the important part of our surgery. You have to do good revision of all part of abdominal wall, abdominal cavity, and especially we have to spend a couple of time to check right part of abdominal cavity, because believe me that if you do this step systematically, you can find approximately 7% of nodule, not only left side of bowel, and the right side too. Example, this case confirmed my opinion, and we found this endometriotic tissue on the terminal part of ileus. You will see this pathologic tissue. Second step is to start to mobilize of left side of bowel. The rule is not cut the tissue between bowel and uterus before you open pararectal bilateral space. It's a very important rule to prevent a lot of complications. You cut the fascia, I told you, you know well this anatomical and surgical space. It should be better to be in abdominal cavity, not open retroperitoneal space. But we need the mobilization of sigmoid as large as possible, because if you decide to do resection of bowel and do anastomosis later, it should be better to mobilize sigmoid as well as possible to prevent any tension during anastomosis. Again, we open retroperitoneal space and try to find the right place between ureter and pararectal fat. The name of this space is Akabayashi. You know well, it's very important surgical space. If you work in this right space, the number of complications is much less. You see ureter, and you see the right space between pararectal fat and ureter. I absolutely agree with my previous speaker that fat belong to bladder and bowel, and that is why we it should be better to stay between fat and pelvic wall. Again, we mobilize more sigmoid to prepare all for bowel resection. Identify ureter. This is gonad vessel. Find promontorium. Promontorium is here. And this is the right place between ureter and the rectum. Ureter is here. From time to time, we used mechanical separation of tissue, and I'm not sure that it's a good way, but if you are too close to the ureter, maybe it should be better to separate tissue mechanically. This is a good example how is safe for ureter. This is the right place, and a fat is our friend, not an enemy. We are continue our dissection. And next step to restoration of anatomy of adnexal, left side. This patient had 2 previous laparoscopic procedure. That is why it's not only endometriotic lesions, it's post-op lesions too. This is a very important space, lateral pararectal space, and we need to open this space as large as possible to find the healthy tissue up to the nodule. And again, I repeat my rule, it's not only my rule, don't touch this nodule and don't try to cut the bowel from the uterus before you open lateral pararectal space. We change our dissection from left side to right side, open the peritoneum, open the retroperitoneal space, identify the ureter. This is the right ureter. This tissue should be removed because you see this is endometriotic lesions. We are continuing our dissection. And again, if we are too close to the ureter, it should be better to use mechanical separation of tissue because in this maneuver, we can prevent the thermal injury of ureter. Again, the goal of our dissection is right pararectal space. You see well this tissue medially from the ureter. You can back later in this area to remove all endometriotic tissue. This is a time to cut the adhesion between nodule and uterus. And you can see how easy to do this procedure if you use intravaginal manipulator. This is the same technique, shaving technique, which we are using during shaving of nodule from the bowel. You see the position of intravaginal probe. It helps us to identify fornix of vaginal and cut all pathologic tissue from the vaginal wall. This is the right hypogastric nerve, and now we have to decide to remove all pathologic tissue from the nerve or save a couple of endometriotic lesions on the nerve, but prevent the injury of nerve and prevent the lot of functional complication in post-op period. This is the right space between vaginal and rectum. We open rectovaginal septum. And again, you see how the vaginal probe is useful in this step of surgery. We have to remove this tissue and try to prevent the open of vaginal, because you know, if you do anastomosis and colorectal resection and colpotomy, the number of complication is 2 times higher in group of two lines of injury, bowel and vagina. You see well the healthy tissue on the posterior wall of vaginal, and we are continuing our dissection to prepare all walls for bowel resection. I totally agree with my colleague who demonstrated a very nice ultrasound exam before surgery, because I do myself ultrasound, and it's very important to know your surgical strategy before surgery, not after or during surgery, before surgery. And in this case, this lady had the big nodule more than 7 centimeters and more than 2 centimeters of involved of bowel wall. That is why we started to do preparation of bowel, and the beginner of this procedure know well that it's only one right procedure for this case. We have to be between pelvic side and the fat, and cut this fascia close to the line of our stapler. It's very important to save this fat around the rectum. This is the right place to dissect and prepare rectosigmoid part of bowel for resection. You see well the place of right hypogastric nerve. And again, now we use rectal probe, and you see how is useful in this step. You can identify the health part of bowel wall, rectum wall. You see well. And now we are continuing to cut this nodule from rectum and prepare this region to use stapler. This is a rectal probe. You have to cut all tissue around the wall. This is a very important part of our surgery, because you have to spend enough time to prepare bowel, to remove all pathologic tissue and have a healthy tissue in the line of our resection. Because if you use the stapler twice, the number of leakage of anastomosis is 2 times higher. But if you prepare this region absolutely right, you use only one step of stapler, and that is why the number of leakage of anastomosis is less. Oh, sorry. Okay, you see that it's a lot of spaces around the rectum and sigmoid. It's very important to organize this space and prepare the tissue for resection and anastomosis. And again, how is useful, I mean, a rectal probe. If you compare the picture before and after dissection, you feel different. Thank you very much. And I would like to underline again that now we need to talk about the new surgical generation. We need to learn pelvic surgeon, because if you invite others specialized in your operation room proctologist, neurologist, general surgeon. I do believe that only gynecologists should be conducting this orchestra. And if you do this procedure from the beginning to the end, I think the result will be better. And you can, it's not oncologic procedure, it's really endometriosis procedure. And it's a big difference to do this kind of surgery if you do like a gynecologist. Thank you very much again.
Thank you very much, Alexander. Thanks for that wonderful talk. So there's a question to you, and that is whether, in addition to the Pelosi, you're using a probe in the vagina, because I think most people, this question is asked because most people will use a rectal probe and a Pelosi or use some uterine manipulator, but not a vaginal probe. And you talked about that, and could you please clarify that?
Yeah, we use the same probe, but first step to insert vaginally. And after, when I mobilized the cul-de-sac, I changed the position of probe from vaginal to rectum. Maybe somebody decide to use only rectal probe, but when I cut the tissue from fornix of vaginal, it should be better to identify fornix very well, and that is why you can prevent, the example, cut of vaginal wall. Maybe for me, it more easily to cut this tissue if I use vaginal probe. I recommend it.
Yeah, I think that sounds very reasonable, and I think that's something that we don't think about, and I think it's be a useful thing. So thanks once again. So we will move on to the next talk, which will be by Dr. Kirana Arabage. So before that, the usual advertising break. Thank you, Alexander. Thank you very much. So we're coming to the final of the experts' presentations, and again, I am pleased to introduce. Sorry, I'm pleased to introduce Sri Lankan, who is now working in Oxford. Dr. Kiran Arambage obtained his primary qualification from Sri Lanka, and he's a consultant gynecologist based at the John Radcliffe Hospital in Oxford, and since he's been there for over 6 years now. He works as it's a British Society for Gynecological Endoscopy accredited endometriosis center at Oxford. He's the lead for gynecological endoscopic surgical training in the Oxford Postgraduate Deanery. He's completed his MSc in Advanced Gynecological Endoscopy with merit, based at the University of Surrey. He then completed a specialist training in Advanced Gynecological Surgery at the John Radcliffe Hospital. He won the RCOG Bernard Baron Traveling Fellowship to train in centers of excellence in France and in Australia. He's a council member of the British Society for Gynecological Endoscopy and a member of the Medical Advisory Panel for Endometriosis UK. So you can't have a better person to speak on this. We're looking forward to your talk. Kirana, it's your time now. Thank you.
Thank you very much, Prof. Senanaik and the team of Endometriosis Association of Sri Lanka for giving me this opportunity. And it's a great pleasure and honor to be in the panelist list, and also to give this, share my experience on the topic on my approach to obliterated cul-de-sac disease. So I'm going to share my videos now, sorry, presentation. Okay, so my approach is based on lots of factors. It's not just my own, to be honest with you. I think it's based on my experience, which I have gained during my independent practice. Before that, more importantly, I think I had great trainers who passionately trained me to do and look after patients who's been suffering from severe endometriosis. And not only that, and the scientific literature has contributed to this talk, what you're hearing today. So any approach to obliterated cul-de-sac disease, in my opinion, should based on the patient's experience, what they're going through. Severe endometriosis is a debilitating, disabling condition. It can not only affect the female, it can affect their social life, education, relationships, and then the whole world can be destroyed because of that. And I have met so many women who's been suffering from this debilitating disease over the years. So when you have, as a doctor, when you have the opportunity to look after them, it has to be really serious approach. And then, I think my most important priority of the approach to my management is the patient experience, keeping in heart. So I wanted to try and get the best symptomatic improvement for the patients. And according to the national benchmark figure, it's 5 out of 10. And also, it is evident that this sort of surgery will help to improve the conception. And surgical procedures doesn't come with everything fantastic, and it involves the complications. And organ-related injuries is 1 to 2 out of 100 based on the BSG landmark paper published in BMJ in 2017-18, which involves about 5,000 patients. And so the patient safety is very important. And so no point in doing it if the clinician is not improving the confidence and competence. So when you're performing this sort of surgery, and you should continue to improve your confidence and competence. So therefore, then you can train your colleagues and juniors because you have a stepwise systematic approach, and then that'll essentially shorten their learning curve. I mean, these days, we are in quite a bit of hot water with the clinical governance. So it's very important to comply with the clinical governance process, and also to be able to reflect when things goes wrong. So because if you have an approach which demonstrate, okay, we can reverse back and think about what happened. Oh, this is what I should do next. So that sort of approach, I think we all should have. And I think listening to my speakers before me, and I think they all had more or less the same approach. So we have some overlaps here as well. So my surgical approach to cul-de-sac disease is actually these 5 bases. These are the 5 things I do all the time. And endometriosis itself is a disease which is a sticky disease, right? And it gives you a frozen pelvis. And about 20 years ago, 15, 20 years ago, it is classified as an inoperable condition. So the reason is adhesions. Adhesions will actually destroy the anatomy. You couldn't find out which bit is which, and you can't find the uterus, and it's all frozen. So the second important approach is preserving pelvic organs structurally and functionally. Therefore, unnecessary dissections should be avoided to minimize surgical scars, surgical adhesions as well. So ultimately, what we are trying to do is to try and restore the anatomy. But that anatomy, when you do the adhesion analysis, is not the normal anatomy still. You have lots of glue, and because it's a gluing of the pelvis. So glue is endometriosis. So, sorry about it. So once you restore anatomy, and the next step is, more importantly, is to treat endometriosis by excision and or ablation. And also, we need to keep in our mind to take all the precautions to prevent recurrences. Because I could remember, I think Shami or somebody said, the first operation is the last operation. That is absolutely true. I think you should go there with a plan. You go there and you do everything and come out. And also, sometimes it's not quite straightforward. We might have to call a colleague or a colorectal surgeon or a urologist to come and give us a hand, but that's fine. It happens very rarely. And yeah, and so looking at the BSGE database, and BSGE is the British Society for Gynae Endoscopy, which pioneering the endometriosis related matters. And they have come up with, okay, so what does it really mean? Everybody's saying, okay, stage 4 endometriosis, we have to deal with it. So they come up with a plan. Okay, so if you see the first picture on the right upper corner, there's a rectovaginal nodule there. So then this procedure is a pararectal dissection, like my esteemed colleagues mentioned, right? And then after that, there's the third picture, which is the left bottom corner one, demonstrate the going into the rectovaginal space. And the last one you can see, and if you compare the both, and loads of endometriosis, I mean, almost all the endometriosis has been either excised or ablated. So then this pelvis is free of endometriosis, no residual disease. So the maximum site reduction is considered as one of the most important step of these patients. So more and more I treat these patients, that is very evident. And these are some of the pictures, and you know, even though there's no full complete cul-de-sac obliteration, you can see partial obliteration, but still quite a significant deep infiltrating endometriosis in all these pictures, and involving the ovaries, and then the bowel, and then the uterus. You can see adenomyotic uteruses. I mean, it is a disease which involves all pelvic organs and non-gynecological organs as well. So we should have a approach, surgical steps to complete obliteration of cul-de-sac disease, to tackle basically this nasty disease. So my approach is based on these 7 principles. Basically, you need to have a good abdominopelvic survey to map out the disease and to find out, okay, where is the disease? Sometimes it's very difficult because you need to, you can't remember. Sometimes it's like everywhere, right? So often I tell my registrar, look, I mean, we're going to be doing the posterior compartment first, but remember, there's one nodule in the uterosacral fossa, we might forget it. Or in the gutter or close to the diaphragm up there, because you might not go there again, because when you finished this sort of long surgeries, it takes about 3-4 hours. So it's very important to map out. And then, like everybody else said, I think mobilization of sigmoid colon medially is the best way to gain access to the left adnexia, and the left side wall has to be done early. And I think if you're going for a bowel resection kind of surgeries, or even for some of the other bowel shaving procedures, it is very important to do it, like sometimes you have to do it close to the kidney, that level, because otherwise you won't be able to get a proper medial mobilization of the rectosigmoid colon. So what are you trying to achieve? And gaining access to left adnexia means once you go down and you see, first thing you meet is pelvic brim on your right hand side, sacral promontory, on your left hand side, major vessels. On top of the major vessels, left common iliac vessel, what you try to find out is the ureter. And the ureter is definitely, and almost all the time, is going to be medial to IP ligament or ovarian vessels. So it's important that you try and, when you train the trainees, and it's very important to find out, okay, this is ovary, and if you come down, this is IP. So the ureter at that level has to be medial to IP ligament. I mean, most of the time, I would say, 98% of the time. So sometimes the endometriotic nodule can pull the IP medially, and then leaving the ureter on the other side. Very rare. I mean, a handful of cases, like a couple of cases, I came across that. So that is one of the rules. And once you are in the left pelvic side wall, and once you identify the ureter, and it's very important to recognize the hypogastric nerve from the level of pelvic brim. And if you go really down, and you'll be able to find out the hypogastric nerve next to coming off from the sacral promontory. So once you get those 2 important organs, and then you can go into pararectal space, and there's nothing much in the pararectal space, to be honest with you. And you can, like all my other colleagues mentioned, and fat is your friend, and you carry on dissecting in the fat planes, and without disturbing the disease, because the fat is your friend, and also you dissect only on the healthy tissues. Often. And so the right side, you need to go to the right side. And the right side, again, if you are facing with complete obliteration of the cul-de-sac, you start from the pelvic brim and go down. So either you want to do pararectal dissection because the ureters may be far away. If you're going to start doing pararectal dissection straight away from the right side, you need to stay really close to the bowel. But good practice is actually do ureterolysis and see the hypogastric nerve and preserve them before going in that direction. So once you actually establish or restore the anatomy of some kind, you can see uterus on one side, the ovary on the other sides, and the side walls. Yeah, now you know. Like Shami mentioned, so you isolate the deep infiltrating endometriosis and superficial. So for the DIE, you excise everything. So when you excise, I think the technique I use often is isolating the nodule. So often it's a nodule somewhere close to a nerve, close to a ureter, close to a bowel. So you isolate the nodule and dissect in the healthy tissues. You can do it all the time. And then when you do it, and you can actually, sometimes if it is on the ureter, you have to shave the ureter off, or on the bowel, you have to do that. And if it is too much, you might want to get your other specialist colleagues involved in. So then so the other most important thing is sometimes we all feel, okay, additionalization is done, additionalization is done, but that's not good enough. That's the first step of our whole file. So what you need to do is actually to try and find out and treat superficial endometriosis, because equally, I mean, that can give the most pain, who knows? But I think it's very important to really chase the superficial endometriosis and treat it properly, and you can use anything, any energy modalities safely. And finally, you check for integrity of the organs and achieve hemostasis and suction lavage. Make sure if you have anti-adhesion barriers which you can rely on, you can use one of them to make sure everything is fine. So cul-de-sac, as we discussed, it is actually posteriorly by the anterior rectum and anteriorly by the uterus, vagina, cervix, and pelvic side walls on the other side. This can be obliterated because of various things. And in my simple diagrammatic representation, if you think the top oval-shaped structure is your uterus and the bladder, these two sides you have ovarian tubes, fallopian tubes, and at the bottom you have two other structures, rectum and the vagina. So two structures from each, and sometimes they can be like this, sometimes they can be like this, right? And if you really think quite abstract way, this is how you think about it. But I mean, that applies, the principles should apply to the same, the previous principles which I described should actually be able to deal with that kind of disease. So, so say, for example, when you go into pelvis, you do diagnostic laparoscopy, and it's just frozen and you can't see anything. Sometimes 4 or 5 layers of bowel hanging from the abdomen, you can't see anything, right? Not the anterior or the posterior compartment. So you're helpless. So what do? And you need to find out what are the immobile structures there. So the bones cannot be changed. Vessels, big vessels will never be changed. It'll be there at the same place, right? And there are partially mobile structures you can rely on. Oh, I can see the uterus. Right, fine. So anterior to uterus, this is the structure I'm going to find. And I can't find the bladder to the posterior, bladder in the posterior aspect of the uterus. Likewise, and you can work your way out. And when you do that and you find out, you stick to the principles, and also you can actually progress with your surgery. And then the mobile structures are the tricky ones. That's why we have a lot of injuries with regards to ureters and nerves and the bowel and the fallopian tubes. Sometimes, often fallopian tubes actually curled around the endometriomas or ovaries, and you can't see it at all. And right, so this is one of the landmark papers which was published at the PMJ Open by the British Endometriosis Centers in 2017. It's a little old, but it's very helpful, and involving about 5,000. This is a prospective cohort study. The objective is to estimate the effectiveness and safety of laparoscopic surgical excision of rectovaginal endometriosis. So participants nearly 5,000, and the intervention is as mentioned. So what did they find at the end after assessing 5,000 across about 50 centers in the country? So the median pre-treatment score was 55 out of 100, and it has gone up to 80 after 6 months post-operatively. And significant improvement in the quality of life parameters, even if you achieve a 5 out of 10 symptomatic relief, and the chance of you achieving the same thing at the end of 2 years is more or less the same. And one could ask, okay, you do this really nasty surgery. Lots of complications, isn't it? But that's not really true. And so the complications related to organ injuries is about 1 to 2%. If you look at this prospective study, and also overall incidence of complications which involve bleeding, infection, UTIs, pyelonephritis, and bleeding, hemorrhaging, and things like that. And so, but I think most of those complications, even though it's intraoperative or postoperative, can be managed, but not not the organ-related injuries. So I'm going to talk to you about 2 cases and 2 videos, if time permits. Both of them have a stage 4 endometriosis with posterior compartment disease, and I'll talk you through the video. And the first one, which take about 13 minutes, the second one is about 10 minutes, if I have the time. But the second one is for the hysterectomy as well. So this is a patient who's been referred by a gynecology consultant colleagues from outside Oxford. So we are tertiary referral center, and she's 37 years old, teacher, Nalit. These are the pain scores. You can see the period is 10 out of 10, and she takes 2 days of sick leave a month. Which is significant, and you can't keep going. And even in school or everywhere, they'll ask you what is happening every 2-3 days a month, and you're off sick, and it's a problem. And not only off sick, and because the family members have to deal with it, and often in the bed and hot water bottles, and it's really, really debilitating. Bowel symptoms, cyclical dysgeusia, non-cyclical dysgeusia, as you can see. It's terrible. And not only that, and very rarely I hear from patients, and she has been experiencing soiling, experiences soiling of underwear during her periods, which is very disturbing. And also urinary symptoms, deep dyspareunia, and she's abstained from having sex for the last 8 months. And so the MRI scan has clearly said that the bilateral ovaries, sigmoid, everything is stuck together, frozen pelvis, but they could not see any significant bowel disease. MRI sensitivity is 80%. Prabodhana gave a fantastic itch in the morning, late early afternoon Sri Lankan time, and which is, he touched base on everything, and ultrasound scan as well as MRI scan, both. We do quite a lot of ultrasound scan. I run an endo ultrasound scan clinic in my hospital, weekly, 2 weekly basis, and so we find the sensitivity is more or less the same. So we can patient after discuss, because she tried all the medical treatment and some of the GnRH, and she refused to have it. So she chose to have this particular procedure, laparoscopic excision of RVS, endometriosis, adenolysis, tubal dye test, because she wanted to fall pregnant as well. She's 37 for right reasons. And so we have consented based on the evidence we have. So I'm just gonna share the screen, and again, I had to spend quite a bit of time doing editing, but it's fun. Okay. Okay, sorry. So let's see what we find. So that's the pelvic abdominal survey. You can see some of the endometriosis in the cecum as well. A bit of a you can see the anterior compartment. Still you can see lots of endo there, and then some hair on the iliac vessels. So we are doing sigmoid mobilization, so we are at the pelvic brim. We are trying to find the ureter. So the instruments, basically my ports are like 3 ports. One is suprapubic. On this occasion, I do ipsilateral surgery as well. This is contralateral, but 4 ports involving 1 umbilicus as well. So so the instruments I'm using is laparoscopic pledget, you just seen, and harmonic device as well. So I find laparoscopic pledgets very interesting, and I think the first-hand experience I had when I was doing a live surgical workshop, I think about 3 years ago in Sri Lanka, in Colombo South, and I thought, wow, that's really good. And I asked our guys to please purchase them, and they did, and it really works. Now you see this bleeder right next to the left ureter, but you need to, because it's a vessel, I could not really try and get a swab to do it, But if you move the ureter away and you can burn it, and it's very safe. Ureters are thick muscular tubes. If you talk to your urologist, and quick bus on the right place is fine. So left side pararectal dissections. So if you can see the instruments I use, and it's really close together when you start, because that way you're applying maximum sort of power to move the tissues away. So I'm using laparoscopic pleasures to do the lateral dissection of the left side ureter. As you can see, quite a bit of endometriosis on the ureter as well. There's no choice, because I mean, this patient did not have hydroureter, but you know, if you leave it for about a couple of years, I'm sure she can have it. So I'm just trying to use the, it is very safe to use Maryland forceps on the ureter opening with, curves towards the ureter. So, and then, but you need to use, we need to be very gentle, and I'm applying traction, counter traction now, doing more medial dissection, now in the paravesical fossa. As you can see, there's a little bit of dissection there. You can see that there's external extrinsic ureteric nodule. I'm trying to do my best to get it done by blunt dissection, but it is a stubborn nodule there. So then you need to decide, okay, you need to go for a sharp dissection. So I'm bringing my cold knives, cold scissors in, and so I need to get that tiny bit done. Once you give that first cut, still, then you can carry on with the blunt dissection. And please don't worry about bleeding next to the ureter. You have loads of things to deal with it. You can actually get swab in, mastoid swab, which is quite effective. And often these are venous blood. I mean, you can use bipolar, rarely you can use harmonic as well, because the lateral thermal spread is about 1 millimeter. So as you can see, I'm cutting right next to the ureter, and I'm just because so I thought, okay, I'm going to quickly give a bus. That's fine, and so quick, sharp bus like a bipolar at 30 is fine, but try not to do too often, and because it can damage the adventitia. If you have an adventitial damage up to 2 to 3 centimeters, that can cause problem. So as you can, the reason why I'm doing this lateral dissection to the ureter, I'm in the paravesical, I'm in the Okabashi space, still right next to the ureter, and yeah, so now I've done the ureterolysis on that side. I have to do it up to that level. The reason is, and because the disease is really right next to the ureter, but as opposed to the right side, this is the right side now. And so ureter is fine right up there in the ovary. So that's why I have used the harmonic right next to the bowel. And see, I mean, the fat is your friend. It's nice, and the gas is actually helping to dissect the pararectal space, and it's a medial pararectal space you're dissecting, like Dhammika mentioned, Okabashi space. And also, yeah, so likewise, now you carry on dissecting on the right pararectal space. And so if you can see, I'm quite okay to cut right next to the bowel there, because the lateral thermal spread with this instrument is about 1 millimeter. And so it's a safe device, and you can dissect. So what you do is you do always pararectal dissection in the healthy tissues. So remember, I told you it's isolating the nodule. So you dissect pararectally, and you're isolating the nodule. Once you have more information there, you can go in the middle. But I've seen some of them go straight in the middle. I'm not sure whether anybody has a ultrasonic eyes to find out what is behind them. But when you do pararectal dissection and isolate the nodule, you know, you have an understanding what is around the nodule, so how far the bowel is away from. So that's the kind of a technique I use for most of my nodules, wherever they are. So you see the left side ovary and tube. Now you can see there's a tube on the one on the left side, lateral to the ovary. Nothing was seen when you went in the first place. So sometimes you just using sucker with, I mean, it'll do the job. Having a little bleeds here and there, and I wouldn't worry too much. I would quite like to use the blunt dissection as well as the sharp dissection. And when I started doing this about 7-8 years ago, and I was actually really meticulous, and I wanted to get all the bleeding sorted. But I mean, later on, I thought what I'm trying to achieve, because this venous blood is going to anyway stop bleeding. But I don't want it to bleed, continue to bleed, because that will actually affect your surgical planes. You rather not have any bleeding if you can avoid. But if you have it, you can try and really stop it, or you can put your mastoid swab if it is around. So you're now trying to go dissect into the rectosigmoid area, but still I'm on the right hand side. So I'm using traction, counter traction, and so going in, opening, and just putting the harmonic as well. So in this particular occasion, I have used, this is in the vagina, I've used a V-Care uterine manipulator. So that's why I can nicely delineate, I know this is vagina, right, for sure, because I know that I can feel the plastic. So on this particular occasion, I used a V-Care uterine manipulator, because that had helped for me to sort of find out where the rectum and the vagina. If I don't have it, I can put a Sorbonne stick in the vagina. It's I think beneficial, and it's reassuring to put a Sorbonne stick in the vagina than a rectal probe, because rectal probe can be moving anywhere. So I'm just doing some of the shaving of superficial endometriosis on the sigmoid colon using cold scissors, now using harmonic. In our center, gynecologists are love to do all the shaving. So we do all the shaving, and that's the understanding we have with the colorectal surgeons and for years, and that works very well for us. So
Kiran, sorry to interrupt. You got 3 more minutes. 3 more minutes.
Sure.
Yeah, thank you.
So as you can see, it's continuing. And again, sharp dissections as well. That involves quite a lot of perirectal fat as well. Because this is a talk about cul-de-sac disease, so I have not, I'm not showing you any other type of disease here. So I'll try and start. So see, I mean, as you see, I am now going around and using the diathermy to treat the superficial endometriosis. So going back to the, I want to share something new here, and okay. So this is the patient's 6 months questionnaire. Sorry. This is a patient's 6 months questionnaire. And as you can see, so we send it every 6 months, pre-operatively, post-operatively, 6 months, 12 months, 2 years, to same questionnaire to everybody who had this kind of operation. So as you can see, this is done on the 24th of the 2nd, 2020. So the patient who had a 10 out of 10, and actually she's now completing this. So she said, these are all patient reported. My endometriosis clinical nurse specialists send these the questionnaires to the patient, and then they collect it off. The 6 months visit is with them. I don't see them, but I picked up from the database, and because I wanted to find out how, I wanted to present this case to the conference. So then I found out, oh, wow, this is really good. And premenstrual pain is actually non-existing, and she has been doing really well. And also, but she still have pain opening bars at other times and lower back pain as well. But these symptoms can be due to musculoskeletal pain. I mean, patients with endometriosis do not suffer only from endometriosis. They can suffer from musculoskeletal, neuropathic, visceral type of pain. So to treat them, we have different team who are specialized in those areas, and often involving with the pelvic pain physiotherapist as well as a psychologist. So if you go down, further down, there's a, so she is actually using, she's got a marina because she was going to go to China as a teacher. And so she wanted to have a marina fitted. She thought, okay, I'll leave the, so she's got a marina that may be helping as well up to some extent. And so if you look at the best imaginable health state, and so that's 90, and she has mentioned 30 in the pre-op one. So that has really helped. And I have no problems of performing my usual activities, pelvic discomfort, anxiety, mobility, and self-care is all unaffected. So that's a good story. Often we have similar results, but sometimes we don't. But when you don't have it after a surgery like this, you need to think. I mean, the first thing you should not think about is the recurrence of endometriosis. If you have achieved a good cyto reduction, you need to think about the other causes like musculoskeletal, visceral pain, often related to physical activity. I think my time is over, and I'm sorry I was not able to show you the other video. Thank you.
Thank you, Karina. So there is a question for you as well. We'll ask it on the other side of a short video we're going to show. Thank you very much for that presentation. The new perspective about sending questionnaires to the patients after the things, and rather than thinking we've done a wonderful job, and to asking them how it matters. So please don't go away. We have a very short video to convince you to come to Sri Lanka in October for our conference. And after that, we have some interesting questions, just a few. And so we'll come back to you after this video.
Thank you very much.
So thank you. So we have a few questions from the participants for the audience, the experts. The first is if you achieve a good clearance of the endometriosis in a woman who is not attempting conception, would you keep her on long-term suppression? And if so, what would be that? Would somebody like to, Shamita, would you have any views on that?
Yep. Yes, I'm happy to answer that. Look, I think the evidence is definitely showing that in the setting of hormonal treatment, the post-surgical management with hormonal treatment seems to confer a big benefit for the patient, especially in terms of disease prevention or recurrence, and also in terms of relapse and requiring for a future surgery. So I would encourage hormonal treatment. The only thing that I'm a little bit wary about is the type of hormonal treatment that we would encourage. Again, minimalistic approach, especially with any hormonal treatment. So I would start with something small like a marine IUD, localized action. We know that the levonorgestrel IUD system has evidence mounting regarding how it's effective in terms of endometriosis and adenomyosis, and it's a insert and forget device. And in terms of quality of life for women, it actually is a great device for women. As we know, the oral contraceptive pill is probably about 40% effective in that area, and it's a daily pill taking device as well, and it's got lots of side effects. In terms of GnRH analogs, the only other concern that I have with long-term treatment is that we seem to be getting some evidence behind the effect of GnRH analog on the enteric nervous system, and how women who have had used long-term GnRH analogs, they do studies at the sort of the histopathological level, some of that nervous system dies and it actually doesn't come back. So I'm part of a big paper that's coming out of the Bordeaux team at France, where we're looking at all the gastrointestinal outcomes, about 1,500 women, and that's been a really interesting aspect as well. So yes to hormones, again, the smallest amount of hormone that will conquer the benefit is best for the patient.
So could you say that interesting thing you said about, about the nerves dying and not coming back?
Yes, it's very interesting. So there's a number of papers that are coming out about the GnRH analogs and how they are affecting that enteric nervous system. So I think there'll be lots of more research coming out. These initial papers are like in the lab setting, looking at like cutting the bowel and looking at the enteric nervous system. But I think there'll be lots of studies coming out with functional outcomes as the years go. So it's something to be wary about.
Thank you. Would anybody else want to say about long-term suppression in women who seem to have had good clearance of the lesions? Okay, I'll move on to the next question. Just received. Yeah.
Sorry. I think just to add a couple of comments. I think I agree with while agreeing with Shami. And I think some of the patients we have seen in our chronic pelvic pain clinic who's been on GnRH analog for long term, like 15 years, some of them, and I think they have. I'm sure you have. You agree, and Shami as well. And some of them actually do very well. But I think when it comes to side effects or anything like that, it's not for everybody. And yes, I think there are some of the patients who actually suffer from really bad adverse effects due to GnRH. But if you have given a good cytoreduction surgery without a hysterectomy, and sometimes they can be in so much of pain without GnRH because of the adenomyosis bit of it, not because you have done a bad job, or not because it's recur within the next few months or couple of years, or often what the patient comes in, I'm still in pain. You've done a great stuff, but doctor, I'm in pain after 6 weeks or 6 months. So I think that pain is often not due to endometriosis. It can more likely be due to musculoskeletal symptoms and not related to, if you really take a good history, what I'm realizing, they may say, okay, doctor, my pain during periods is fine, but I have this pain which is ongoing every day, which is the worst one, and actually did not get better after surgery as well. So we are talking about musculoskeletal. So therefore we need to refer them to a pelvic pain physiotherapist who can do a fantastic job. And 9 out of 10 times they can sort them out or give a neuropathic medication, which also help them.
In our center, we...
Yeah. Sorry. Alex, yes. Alexander.
Yeah, very short comments. Today, a lot of papers which confirm the changing of tissue, especially glandular tissue from glandular to fibroids. Maybe it's a cause of pain if you prescribe for long period agonized releasing hormone. Maybe it's not good way to treat after surgery, because if the patient doesn't have any kind of symptoms after 6 months of generation, she will have to some symptoms, especially bowel symptoms. Be careful to prescribe for a long period in post-op.
Okay, we'll move on to the next question. Would you advise the primary port insertion at the umbilicus or supraumbilically for these cases, and why? Anybody wants to take that question? Say, for example, if somebody has had a laparotomy for, I mean, we see that all the time. Somebody's had a laparotomy for endometriosis, and it's failed, and you're going in for the next time. Would you do a supraumbilical entry?
I can tell you what we do in our practice. If there's any risk factors, we do either a Palmer's point, or we do a modified approach where wherever the left ipsilateral port would be, I would go through there, and that would either be a varus entry or a direct visual entry. That's what I do. That's what I do in my practice, and then would look up and then decide where the adhesions is, take the adhesions down and go through the umbilicus. If it's got a large multifibroid uterus, say beyond like 16 centimeters, we need the vision, then definitely we go higher up.
Yes, Alex. Yeah.
We use the same technique, and I totally agree with Samida, because Palmer point, it's very safe point to enter in the abdominal cavity, because if you check a lot of data which confirm the safe place, I mean the Palmer place, and it's very useful to use this point and check all abdominal wall to find the safe place to enter the big trocar.
Namika, any comment you want to make about that?
Our practice is usually we will any surgery in the abdomen, because we are not 100% sure exactly what has happened inside. We often do not get recordings or sometimes not pictures. So usually it's always Palmer's point if there's any surgery in the abdomen. And what I just want to add is that over the past 10, 11 years of operating on endometriosis, I've gone 3 times into the stomach while going in at Palmer's point. So the best way to avoid that is to put a nasogastric tube. And it's always best to empty, because sometimes the anesthetist will inadvertently sort of instill some gas there. And you can always ask them to put in an NG tube. And as a routine practice, if I'm going in at Palmer's with a lot of past surgeries, I will ask the anesthetist to put in an NG tube. And preferably, the anesthetist will prefer to insert the NG tube before general anesthetic, before they intubate, actually. So therefore, you can, you'll be a bit unpopular if you ask them to put in the NG tube after they have put in the tube. So it's better to do it before they intubate.
Amphan, is any views? I don't know whether he's still around.
Actually, I never used a PowerPoint for quite more than 10 years. Never use it because I think it's not too essential to use it, and also it's difficult to close the cheese and quite dangerous. I think we got another part that we can use.
Thank you. Could I be the uninvited guest here and say that I have used the suprapubic approach, supraumbilical approach quite a bit, and I use it quite frequently, especially if there's been any previous surgery. And only thing is you have to be careful when you're inserting it. It's if you're used to the umbilicus, that's very much softer tissue, and you got to insert the port slowly. So that's my experience. So we go to the next question. What are the views of the other panelists on the use of preoperative suppressive therapy? Amphan, you talk to us about it, and
because actually in my center the waiting queue is very long. Actually, usually it's 3 months, 6 months, 9 months, some case. So we use a lot of I think it's what I collect is about 60% of case that we will give them for the preoperative because for treat the symptom. But when we use longer time, and we found that it's quite get the benefit. Although from the guideline or systemic review is not sure that it's got a benefit, but I and my colleague, many one is keep pre-operative treatment for the before surgery, and also we continue. Mostly we continue, especially in case that complete operation is very severe case. If you do surgery, this is surgery, and especially in case that cystectomy, some case you will got bleeding from the menstruation before when you destroy the corpus luteum. Sometimes it's just a few days after surgery you call it menstruation. And what you think when the menstruation is refract to the abdominal cavity and the raw surface that do work is still not heal or not heal. So for me, I'm trying to continue medication and protect no more bleeding until at least a few months after that.
Thank you. Anybody else has views about it?
I think what our approach is, we do not use routine preoperative preparatory hormonal supplements unless the patients are on them to alleviate pain symptoms. Yes, we do use GnRH deliberately for the younger patients, like if they are in their 20s, 30s, not had any children, and it got large bilateral endometriomas. So that's the only time we do 2-stage procedures. So during that procedure, after drainage of both endometriomas in the first stage, so we downregulate them for about 3 months before the definitive.
Can't hear, got stuck. Okay, I think Kirana's video is stuck, so I think we will move on to the next question. Is a 0-degree telescope preferred over 30-degree? What is the angle of the scope cube? Hello? Yes, Alexander. Yes, 30 or Z. Yeah.
It's not so important which kind of telescope do you use, 0 or 30 degrees. But I work in a teacher hospital, and that is why it's a lot of people helps me to do the surgery. Well, it's big different to assist if you use 0-degree or 30-degree telescope. If you use 30-degree telescope, it should be better to assist with some experience of cameraman. That is why I prefer to use 0-degree, because it's very easy to change the position of my assistant and see well the my operation picture.
Anybody else thinks it matters? Or, yes, Shamita, yes.
I hope I don't sound too sport, but we do the combination. So we'd start with the 0 degree, and if we can't see around the corners, especially with all the bowel dissections, then we would swap over to a 30 degree, and especially if we're doing a large fibroid at lower adenomyotic uterus and we need to get around the corners, then we swap to a 30 degree and then go back to a 0 degree when we need that type of vision as well. I'm very fortunate that I get to operate with fellows all the time, so they're quite experienced in navigating a 30 degree scope, but that's why I completely agree with your statement.
For me, I think we do only, I think it's 99% is the 0 degree. Very, very few. Although large myeloma, we can do by 0 degree, because actually we don't like to change the camera or something. If we can do that, we can do. It's very, very few that we change to 30 degree.
So, so if you're buying a new scope, it should be a 0 degree. Kiran, the final question is to you. What advantage does a special center in endometriosis in the UK offer to the patients?
I'm sorry about the previous disappearance. I don't know what happened. Technical. And what special things will offer? And I think it's a really good question. And I think everywhere in the world, I think they do different things. And I think in one of our centers, what we do normally at the clinical side, as well as if I talk about our center, we are very much on the clinical side, as well as the research into endometriosis as well. From the clinical perspective, so the teams work really nicely together. There is a nice interface, and we work together and facilitate together to answer some of the unanswered questions from the research point of view. And if you talk about the clinical side, and the BSG accredited endometriosis center has a multiple specialists like you can have access to, and also all the difficult cases, difficult in the sense like difficult to manage. Perhaps you need a other specialist during surgery, and all those multiple specialists are going to be sitting in a endometriosis MDT, where we discuss our patients require MDT approach. So I think that is a unique feature which we will get and make decisions based on the patient's requirement. So I think that is always in our heart, and the patient would tell us before the MDT meetings, we give them a call and find out what do they want to achieve, what are the current symptoms and things like that. This is after the clinic appointment. So then we make a certain suggestions, looking at every aspect and getting we are sitting with a team of pelvic pain specialist, pelvic pain physiotherapist, urologist, colorectal surgeons, and psychologists as well. Some of our gynecologists only do pelvic pain clinics. They do not operate. So they have quite a lot to offer. So they come from a different angle.
Thank you. So it's a really multidisciplinary approach, and
sure.
Yes, thank you. Thank you very much. And I think that concludes the questions. So we have thank you very much to all the panelists for sacrificing your Sunday. And I think it was very, very informative. I really think this has been a very good session. Thanks once again. But there is a formal vote of thanks from our secretary, Dr. Chandana Jayasundar. Thank you.
Good afternoon, ladies and gentlemen. So we have come to the end of this very successful masterclass on surgery on deep endometriosis. And it's my duty as the Secretary of the Endometriosis Association of Sri Lanka to propose a vote of thanks. First, I have to say that this was a novel experience for us. We have not gone totally virtual before. So this is our first one and first, but might not be the last. So that's a new thing for us. So my sincere thanks goes to Professor Hemantha Senanayake, the president of our association, who took the maximum weight of organizing this masterclass and doing it in a very successful and actually a very classy way, a class that is only inherited by himself. And I also would like to thank the other council members of our Endometriosis Association. It's still a small council, but so very active. They all helped us in many ways, even with their very busy schedules, to make this event a success. So thank you all of our council members. Additionally, I mean, we can't have a masterclass without our resource people. And we had eminent speakers today who came around from all around the world and gave their opinion and their experience of how to do pelvic dissection in deeply infiltrating endometriosis or obliterated cul-de-sac. So I'd like to thank them for their efforts in giving us their valuable opinion. So Professor Amphan, Professor Alexander, Dr. Dhammika, Dr. Prabodhana, Dr. Shamita, and Dr. Kirana. Thank you very much for your valuable and very informative input in this area. Lastly, I would like to thank our participants, both internationally and locally, for attending our masterclass. There won't be anything that we can do if we didn't have those participants coming in. We are so delighted to delighted to have such amount of participants, and it brings up our enthusiasm to organize more events like this in the future. So this wasn't our idea, as I told previously. So we tried to concentrate in a single area in the management of endometriosis and try to take different opinions and different experiences in that area. And so a trainee, so this was targeted for the trainees, and so the trainees can get their opinion, they get the opinion of so many experts on a single area, and they can adopt new things that they have devised as well, and ultimately come to their own way of managing endometriosis. Ultimately, our objective is to have a better set of gynecologists who are more trained in endometriosis surgery than what we are or what in the past has been done. So so as the Endometriosis Association of Sri Lanka, that is our main objective, to have so that the patients who are being treated by us would be in better hands in the future. So that would be our objective. So before I conclude my small talk, I would like to invite you all to the 9th Asian Conference on Endometriosis, which should be held on October in Sri Lanka, October 28th, 29th, and 30th. Please keep these dates free. We are trying to hold it in a conventional manner with the vaccine coming in, and the the traveling restrictions are easing off. We hope by October we'll be able to hold it in a conventional way. So please keep updated. We would be sending our flyers. So all the parts, we invite all our participants to join us with that as well. Thank you very much, and have a good night.